I guess
Sam Scamardo
has joined the conference.
Okay.
Hello, morning, everybody.
Put your little goodie bag down for us.
Oh, okay. Well, thanks. Okay, if everyone will connect. Okay, can we get sitting? Oh, here's Mike.
I tried. I gave it a shot. You sure did.
Okay. All right, I'm going to call this meeting to order. And before we get started, I want to make sure we have everyone on the phone. Art, huh? Yeah. I've never been accused of being soft, so. Is Artie on the phone? Artie Locksman? Artie? Sam?
I'm here.
All right. Okay, well, we'll wait for... excuse me. Artie texted me and said he's got a conference call at 8:30 for his business, and then he'll join us as soon as he's done. Okay. All right, so if you'll please rise and do the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America, and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you. All right, this is the annual trust meeting of Mojave County Employee Benefit Trust Fund Board of Trustees. And the first thing to come before us today is the call to public. Is anyone wishing to address this board? Hearing and seeing none, we'll move on. We're going to jump at the request of Erin Collins to number 3, which is the discussion, consideration of, and possible action regarding approval of the minutes of the EBT board meetings held on March 21st, 2019 and November 6th, 2019. I need a motion.
Motion to accept the minutes is read.
Motion and second. All in favor?
Aye.
Opposed? Carried. 4, discussion, consideration of, and possible action regarding trust financial report. It's all yours.
Good morning. So the information that we will review today is under tab 15 and 16. And then do you want your information to remain on the screen? They can just look in their books for all of mine. Oh, I can take that off. It doesn't. Either way. Number 15.
I don't have a tab?
I'm here.
I don't have a 15. I don't have 15. We'll blame it on Karen.
Oh,
she's not even listening.
The actual document?
1 second.
Oh, okay.
Maybe it's just a different tab?
I think so.
Oh, okay.
Yeah.
All right, because the tabs were a little off. All right, no problem. I have 15 here.
Okay. So what is included in tab 15 is actually a draft of the financial statements for both the self-insured retention pool and the employee benefits trust. The primary information on these reports are listed under, in the report itself, it's page number 4. And within your book, it's page 327. And at the top of the page, it says the Mojave County, Arizona Self-Insured Retention Employee Benefit Trust Funds and the Statement of Net Position. So that is actually your balance sheet, if you will, showing the cash and liabilities and fund balance. So under the self-insured column, the primary points there are to essentially look at your cash of the $1,470,000, and to go down, take a look at the difference between the cash and the other assets, about $700,000 to get to the asset total of $2,115,792, and then take a look at the liabilities. What kinds of liabilities do we have outstanding? And basically, the bulk of that is the claims and the judgments payable, which is our, obviously, the invoices that come in for medical claims, $584,379, and then the pension liability is an accounting accrual related to governmental accounting standards. So the net position provides you with unrestricted cash, basically, of $1,191,000 in the self-insurance pool, and then in the employee benefits trust, we follow along similarly, where you go to the top of that, the cash equivalent in the EBT was $10.3 million at the end of the fiscal year. The outstanding claims were $1.5 million, that's the IBNR amount. And then the net position unrestricted is $9.2 million. The following page, which is page 5 of the actual financial report of this draft, provides you the information on basically the income statement, showing you the revenue. For the EBT is about $12.8 million was received. The expenses, $12.4 million, so expenses were less than the income, so we're in a positive position. We also received investment income, which is the interest earned through the Treasurer's Office, allocated to these funds. And for the EBT specifically, excuse me, then the increase in the net position where revenue exceeded expenses was at the end of the year $554,000. So we gained that much throughout last fiscal year. The next page is simply a cash flow that ties out to your cash that was held with the treasurer. So those are the primary pieces of that financial statement. All the other pages are notes and schedules in there that support the numbers. And essentially, it's just important that you have an opportunity to review that and get comfort level in your own head of the indication of our financial position. Are there any questions on the draft? Once we receive the final report, we would distribute it to the board. Okay.
Any questions? Comments?
No.
Anyone on the phone? Sam?
No questions.
Okay.
I'm good. No questions.
Thank you.
All right, the next tab is internal to the county, to Mojave County. And in my book, it's page number 347. And it is the summary page of the Employee Benefit Trust, where it shows the fiscal year 17-18 actuals, then our fiscal year 18-19 pre-audit actuals that we just reviewed, our current year's budget, and then a projection through the end of this June, through June of 2020. And then the final column is what is preliminarily requested into next fiscal year. So when you review those sections in terms of the operating revenue that we're anticipating, we believe that about what is budgeted is what we will receive for the current year, and then next year the amount just carried over the exact same budget, no increases or decreases anticipated in the contributions. The expenses are made up primarily of the claims, which are listed as supplies, if you will. And again, there really no significant changes in the budget amount. We budgeted last year $13,184,858, or I shouldn't say last year, that's for the current year. And then next year, the budget for that has been increased by $1,000 to $13,185,250. The bottom line then, from a budget to budget basis, that we know that if the items that were discussed yesterday are included in what is adopted by all of you, then we may budget to lose just a little bit more money from a budget perspective in case everything were expended. However, you can see from the prior year's actuals from 18, the trust actually gained $414,000 where revenue exceeded expenses, and then we just went through the audit, the draft audit for 2019, where we gained $500,000, and we're projecting for the current year to clear contributions exceeding expenses by at least $195,000. We still have a ways to go between today, March, and June 30, but unless something significantly changed with claims, that's where we would project to be. So long story short, where we would project for this board to end up next year would still be right around $9 million in reserves. And that does allow you an opportunity then if something catastrophic occurred, basically a 2-year window to get to a point where you'd need to adjust the rates. So I think that you're in a good position.
Any questions?
Madam Chairman, I do have a question. What would constitute supplies under this budget?
Okay, that's a good question. So go ahead and turn the page, if you will, and we'll get into the detailed line items are listed. On the first page, when you flipped it over, were revenues and then the personnel expenses. On the top of the next page, on the right-hand side of the book, it starts with supplies and services. So we've got $4,000 budgeted for office supplies. The annual audit cost up to $8,000.
All right.
We have health insurance administration of $1,648,000 that are payments to claims for the claim administration, basically for Meritain and the ACA cost. The flex spending shortage, we budget for $5,000. The wellness program of $20,000. We've got split-funded educational assistance for training in HR, not really for training. The educational assistance is actually education, formal education. The training costs, the travel, and some miscellaneous items. So the bulk of it is actually the health claims.
Thank you.
Yep.
Okay, any other questions?
Madam Chairman?
Yes.
Nope.
So the difference, if you look at actuals and projecteds, we're doing very well, a lot better than what the actual budgeted or requested numbers show, and that's because you're estimating conservatively. It appears like $900,000 over the past year on the claims on the supplies. So that would make up the difference, basically, right?
Yes.
Right.
Right. Correct. Yep.
Correct. Thank you.
That's it? Okay, I just want to take a minute and thank Erin Collins and Coral for, again, since I've been on this board, we've just kept going up and maintaining, and it's been very well run. And I want to thank the employees for doing their part in keeping costs down, and I'm very happy with these numbers, so thank you. Okay.
Madam Chairman?
Yes.
And this is a timing issue. There are some very significant but minor changes in our HR department that actually will impact the budget that you're approving. I was wondering when that would be, the new initiatives there would be presented.
Under the personnel expenses for the wages, when we had our pre-meeting, we took off the extra person, so that is no longer on the budget. So we will be requesting just the same amount that was budgeted last year to be carried over for this year. I think it's a $54,000 difference So that has been taken off the budget. It shows up here, but when we work the final budget, that will be taken out.
Thank you, Madam Chairman.
Thank you very much. Okay, moving on. Number 5. Do we have to accept the financials? Now? Yeah. Okay. So I need a motion to accept the trust financial budget. Is that it? What's the motion? The financial report. Financial report.
I make a motion to accept the financial report.
Second.
Great.
Second.
All in favor?
Aye.
Opposed? Motion carried. Next up, discussion, consideration of, and possible action regarding wellness dental outreach campaign. Brush your teeth. There you go.
If only it were that simple. Good morning, Madam Chair and trustees. This is Missy with ECA. So this item I actually highlighted yesterday during my presentation, and basically just as a reminder, this was to promote and increase preventive cleaning through a quarterly marketing campaign, and it would end with a raffle for an electric toothbrush provided by Delta Dental. And so essentially what we would do is evaluate before the program kicks off and then after the program and determine if we're seeing an increase in utilization of the preventive cleaning. On the second page of the memo, you'll actually see the flyer that was created. The flyer would be no cost, and if we would push out any postcards directly to the higher risk members who had no cleanings for 2 years, that cost would come out of the existing $20,000 budget that's there for Mojave County already for the wellness program. And so basically what we were looking for is just approval to move forward with this campaign. And I'm happy to answer any specific questions you might have regarding it.
Thank you. Any questions? There are none. So this is just
Okay, that's all I had.
the dental outreach campaign, but there's no cost to it.
That is correct. There's no
Okay.
additional budgetary impact.
Very good. But we still have to vote to accept it? Or is that just a report?
You know, Madam Chair, there
I
was
believe
confusion,
sorry.
but I believe, and Missy, jump in if I'm wrong, but I believe that the impression was that launching this type of an activity would require approval by the trustees.
Okay. So I need a motion to approve.
Move to approve the dental outreach campaign as recommended.
Second.
All in favor?
Aye.
Aye.
Opposed? Motion carries. Thank you very much.
Thank you.
Discussion, consideration of, and possible action regarding basic life and accidental life and dismemberment, voluntary term life, and short-term disability contract award effective July 1st, 2020.
Okay, so Madam Chair and trustees, you heard an admittedly somewhat sped-up presentation from Bill Oakes with Securian yesterday, but just to hit the high points
Has
on
joined
this,
the
and then
conference.
I'm aware there are some questions that one of the trustees has. So what this does is there's three elements to this. One is the basic, which means employer-paid life insurance the county is paying for. It's $50,000 life and $50,000 accidental death for every employee. And then it's the short-term disability policy, which is 100% paid for by the county. Then it's the voluntary term life. So on the basic life, it's actually, again, the coverage is enhanced through two key ways right off the cuff. Number one, it eliminates a benefit reduction that's tied to age at age 70. So once it got to 70, I can't remember, I think it was a 50% reduction. So instead of getting 50,000, they got 25. It eliminates that and restores anybody who's 70 and up back to the full benefit. Okay. Secondly, for all first responders and judicial officers and probation and surveillance officers, any of those first responders who are killed in the line of duty, it adds another 100% of the accidental death benefit. So they would get 50,000 life, 50,000 accidental death, and then they would get a first responder benefit of another 50,000. Okay? And then there are other extensions in there. And frankly, the terrible thing about life insurance is it's great to save money and it's great to have benefits, but somebody's got to die for it to pay. But another one that's really key that in our minds, because we see the value of it when we work with HRs, is that to the degree you have somebody with a terminal illness where they have a diagnosis that says they're going to die within a year, basically. Currently, you can get an advanced, it's called a living benefit for up to 70%. That helps a lot when there's a lot of bills to pay. This policy will give them up to 100% of the life amount.
Wait, can you repeat that?
So if you're facing a terminal condition and your physician says this person's going to pass within a year, you can apply to the life carrier for what's called a living benefit. They will give you, in this case, 100% of that $50,000.
Wow, that's very good.
So it's a good one we work with, and we do see those pay. With HRs because they're dealing with things like FMLA where people are off sick. It gives them the ability to say, hey, by the way, here's this thing to help. So we get all of those extensions of benefit on the basic life, and it's a savings projected at $104,000 a year for 5 years. So that 5-year rate guarantee is really critical because one of the concerns is always, are they buying the business? So they took a look at the rates, they looked at the benefits, and it's 104 and change, all things being equal. So it's over $500,000 savings to the county and to the trust, period. The short-term disability is also improved. The current benefit maximum, I believe, is $850 a week. This increases that to $1,900, and what we did is we took a look at what's the highest salary being paid today. So this would cover the highest paid county employees. For the record, it does not count elected officials, and the reason for that is elected officials are always excluded. Their pay is set by statute, and they're going to get it as long as they're in the position. So it does exclude elected officials, which it does today. There's another. Oh, and then this continues what the county is currently doing is if you're off on short-term disability but you have paid leave, what they'll do is take your accrued leave and credit you the value, that a pro rata portion of the value, to get you back to 100%. Okay, and on that, again, we have an annual savings of $31,741 based on expenses today, and that's for a 3-year rate guarantee. So even if the whole thing tanks, these rates are going to hold. So collectively, over the term of the 5 years, this is a $600,000 savings. Absolute, just in writing, $600,000 savings. So when you vote later in your budget, it will incorporate this into the benefit plan as well. You can vote on it now if you want, Madam Chair. I'd be happy to answer any questions. I know Susie has some questions on the voluntary term life, and I'd be happy to go into those as well.
Okay, questions?
Madam Chairman?
Sure.
Erin, I understand, first of all, the removing the cap of 70 years old for life insurances is very good because we know that people are working longer and longer in the job place, and therefore that insurance should remain. So that's a good change. The second one is I have a question regarding transferability of the benefits from the old provider to the new provider. If the employees have purchased, either in the voluntary, a higher level than what the current vendor is providing, are those transferred laterally? Are they grandfathered in so that whatever they purchase under the old provider will be honored under the new provider?
The short answer is yes. So what we did with this, and again, we kind of hung this one on a larger group that we had done, and what we agreed is they agreed to 100% grandfathering, including any that would not conform, okay, to what the current limits are, but frankly, they all conform. So we're okay. So whatever they've got in force is coming over. With the prior carrier, there was a $300,000 limit on the voluntary term life for an employee, but that included the $50,000 that the county had. So theoretically, they could only get an extra $250,000. We know we have people at $300,000. Those are non-conforming. They're coming across at the $300,000 plus the $50,000, and any restriction on that, the fact that it was done essentially incorrectly, these are very old ones, are waived. So long story short, if you have it in force today on the voluntary term life, it's going to come across with no reduction. In addition, we got rid of the 2 sets of rates. So we've got the base rate and we've got the smoker rates, which are higher. They eliminated the smoker rates, and they're going to put them on the lower rates. And we got rid of the age reduction at age 70. So to the degree we've got anybody there, and frankly I don't know, if we have any there today and they've got voluntary term life, they also get rid of the age 70 reduction as well.
Thank you. There's one more, Madam Chairman. How long is this if we're going to approve this contract, how long is this? Are we giving the provider 2 year, 4 year, 5 year?
1 year. The nice thing about it is, the 5-year rate guarantee, actually only protects the trust. So the vendor can actually really, on life insurance contracts, you can term them at any month, at the end of any month. So it's not binding you, it's binding them to guarantee the rates and the terms.
Okay, thank you.
Madam Chair. Is this the time, Erin, to ask about expanding Teladoc and what our charges would be?
Madam Chair Verlin, it's not, and we do have your information for later. We're going to do that when we get to the rates. I've got 8 items to discuss when we do the rate making and the budget building. And we're going to go back. That's item 2 and actually item 8. So we're going to skip 8 also, Madam Chair, and we're going to do both of those under item 2.
Okay, so that will be the last thing we do. 8. It will be 2 and then 8. Is that what
So you're on item 6, Madam Chair?
Right. We're not, you just said 8. Did I misunderstand?
So we're going to go to, do you want to do skip 7 and 8?
You want to go to 8 now?
No, so what we're going to do, Madam Chair, if we could, let's skip 7 and 8. I think we need an action on a vote on item 6,
Okay.
unless you want to incorporate it into the budget later. I think it's clean enough. A motion to approve on Securian would be good, and then we would go pick up on item 9, 10, and 11 and go back, and then go back
Okay.
to the budget.
Okay. I need a motion for item 6.
Which is for the short-term disability and
It's to award the basic life, the short-term disability, and the voluntary term.
I'm sorry, one second. So I'm looking at the agenda, and isn't that number 5?
No,
No.
that's an old. There's so
5
many.
was the dental outreach, on the one I've got.
Okay, I have a different one too.
Have called a public on our sheet, and it was taken off after we submitted. I'm so sorry.
No, that's okay. I just wanted to...
Move to award the basic and additional voluntary term life and short-term disability to Oaks as recommended.
Second.
We have a motion second. All in favor?
Aye.
Aye.
Motion carries. And welcome Artie on the phone.
Thank you.
Okay, so we're going to skip 7, 8. We're going to go to 9.
Okay, so Madam Chair, this is discussion and possible action regarding COVID benefit adjustments, and you have to bear with me on this one because I have to kind of put the outside loop on this. As you as board members and public officials are all dealing with, everything's moving very rapidly. So what's happening is the federal government and our state government are both issuing mandated benefit changes, and so this incorporates what was known at the time of the memo was written. I'm going to adjust it here a bit, and then at the end I'm going to ask you to basically retroactively approve what's already happened because it's the feds and the state have mandated it. But I'm also going to ask that at a minimum you be aware that as this is happening, we're going to have to make changes, and we will be bringing them to you essentially like this one retroactively. Because if the feds mandate it, your summary plan document is amended, period. And that's kind of where we're at with this. Okay, so on this, the one that was voluntary is item 1, on-site wellness activities, and we're asking for retroactive approval of the fact that what we've done is work with HR staff to cancel any on-site wellness activity that involves people coming together. So health risk assessments, skin cancer screenings, anything like that. We have currently canceled them, and Missy, if you're on the phone, or Jade, I believe we've canceled them through the end of April.
We've actually canceled those through, I believe, the middle of May.
The 60-day period.
What is it? Okay, so they're currently canceled for a 60-day period, and that's just the common sense, social distancing, that type of thing. So I'd like you to retroactively approve that, and then authorize us to work with Ken and Jade to announce any future cancellations for additional periods not to exceed 90 days at a time. So what we're asking for is the flexibility to recognize we're in a developing situation and we don't want to create risk for anybody. I'd be happy to answer any question. We will obviously come back to the trustees at future meetings and say, hey, here's where we wound up on all of that. I'm sorry, one last point, if I could, Madam Chair and Berlin. Some of those cancellations may result in the trust paying cancellation fees because what happens is we're doing this a year at a time. A lot of times we're scheduling. What we're attempting to do to mitigate that, kind of on the fly, is what can we reschedule to waive those? Okay, so in the event we can't reschedule them, there will be some charges. So as long as that understanding is in there in any motion, that would be great.
Berlin?
Thank you, Madam Chair. Is it possible to write in future contracts, pandemic situations will allow for no cancellation fees?
The question is it possible to put pandemics or acts of God into the future? I think that would actually be a good idea.
I mean, they happen once in a lifetime, once every 50 years or whatever, but it's just a short little statement, but, it would have saved us whatever cancellation fees we're going to have to pay now.
Agreed. Madam Chair, Berlin agreed. And I'm sure Missy is making a note in her house right now.
Okay, any other questions?
Madam Chairman, I don't understand how, if we have a directive like what we have right now, that those cancellation fees will be imposed. Because some clinics or whatever, I mean, they're even canceling appointments because of the directive of this distancing. I don't understand how they could impose some penalty to us for that, since it's not the fault of the employee for canceling, nor is the fault of Mojave County. So I don't understand that.
Well, the employee won't see any cancellation fees, period. It would be, to the extent that any of them are there, Madam Chair and Susie, it'll be because the contract did not include an acts of God and type thing. So we've had really good luck with our vendors, so we're hopeful, but it will be strictly a business decision that they'll ultimately make in the interest of keeping the relationship with the client.
Okay, thank you.
Any other questions? So I'll need a motion.
Give it a try here.
Okay.
Make a motion that waive all cost shares for COVID testing regardless. Of course, but leave all other applicable cost shares in place for location of testing. Waive all cost shares for teledoc services for both EPL, June 30th. Authorize Tim Cunningham and/or Jade Hunga to work documents or paperwork necessary.
Did you get that? Oh, okay. Does that sound complete?
That's item 2. That's the second one. That's the benefit changes. This is item 1, but Roger, where you were correct was the motion would essentially be under item 1, it would be the wording in A and B, capital A and B would be the wording of the motion.
Okay. Well, I'm kind of lost here.
I'll make the motion.
Let me show you what I'm talking about so you got it.
I make a motion that we retroactively approve the cancellation of on-site skin cancer screenings and authorize Ken and Jade and/or Jade to approve future cancellation of on-site wellness activities for successive periods of up to 90 days through the end of the 2021 plan year, with the understanding that the trustees will be kept in the loop at subsequent meetings of the trust, and employees will be notified as far in advance as possible of any cancellation.
That sounds good?
That's the motion.
Perfect. I second it. Okay, we got a motion and a second. All in favor?
Aye.
Opposed? Motion carries. Discussion, consideration, and possible action, COVID financial impact modeling?
No, we're still on
that was all part.
former agenda item, Madam Chair. So the second part of this is the benefit adjustments. The first one was the wellness.
Wait, I'm all confused now. Right, but I'm following this, the agenda. Page 3, yeah, because we got to follow the agenda. I've never done it this way. All right, so come here and show me, and so we don't keep doing this every time. Right?
So it sounds like something got changed afterward, Jenny.
Okay, well, that should be okay. All right. Couldn't we have all approved all this at once? Because shouldn't it have been on the agenda, 1, 2, 3? I just know what we do for the regular board. Is that okay, Ryan?
I got it.
Is it okay how we're doing it?
We should have broken it.
First part of it, the wellness program, because of that. Now we're doing the second part of that,
Right.
the actual benefits that the investment.
That's correct.
For future reference, it should be on the agenda A, B, C, whatever. 1, 2. Yeah, I understand. Just trying to understand because I've never seen it done like this before. All right, so now,
We're still on the possible action regarding COVID benefits.
yeah, but
Part of it, portion of it.
the first part. So we're on the cost share waivers? Okay. Okay. You okay, Ginny? Okay? You know where we are? I know, I was totally confused too. I know. Okay, so we're on number 2, and that's the cost share waivers for COVID-related testing and teledoc visits.
Thank you, Madam Chair, and apologies for any confusion
That's
on how we
okay.
have that worded. Okay, so the second one, this is actually the federal mandates and the state mandates, and what's happening here is that they're essentially saying they want people to get tested. That's the goal, okay? And they're overriding plan designs in terms of cost shares. And the reason that's so significant is that there's tax implications to it. Okay, so for high deductible health plans, there's a very limited, very defined set of things that you can waive the costs on. They're overriding that, and that's significant. Okay, because we have to do it right, because otherwise employees get crossways with the Internal Revenue Service. The same is true on the EPO plan, to the degree that people were paying costs that were not eligible to be paid for out of flexible spending accounts. So we're dealing with the IRS essentially here. Okay. So what this does, and there is a modification to it since it went out, is it says regardless of where you go for COVID-19 testing, the testing portion, the cost of that testing has to be 100%. And the additional change they added to that is no longer just the test, but the facility portion of it as well. And there's a contrast in here, but before it was just if you went to the ER, we could still say you have to pay your deductible, your copay, your coinsurance, we'll pay 100% of the test. Now they're saying if you go to the ER, all of those associated costs have to be waived. So if the ERs for the doctor visits for urgent care, okay, it all has to be paid with no member cost share. That even sounds clean, but I just want to caution you of this. And we're going to recommend make that approval, make it retroactive so that we comply with federal law. The reality is we're doing it now anyways because the law changed. But my cautionary note to trustees is this: it's not always going to be clean. So what's going to happen is we're going to have people go into the ER because of a car wreck, a broken arm, something else. They go into the ER, and in the course of that, they're going to get tested. Okay, so there's going to be some judgment on how that claim is ultimately paid, and it may result in appeals. So our intent is we've already flagged with Meritain, had conversations. You get a squirrely claim, call us. Let's work through it. And to the degree we can do so with Ken and Jade and HIPAA, and not violating HIPAA, our intent will be to do everything we can to comply with that law. To the degree that anybody is dissatisfied, the cautionary note to you is they're going to come through as additional appeals. So in essence, what we're saying is we're going to do everything we can as vendors with your staff to make sure we comply with both the intent, the letter, and the spirit of that law. If we can't come to a conclusion that we believe is adequate, you may see additional appeals come through to the Board of Trustees. Madam Chair?
Okay, so if I go to the hospital today with a cough and they check me out and I believe I have COVID, but they won't give me the test because I don't reach that bar that they have, everything stays the same, or are you saying that even that goes into the 100%?
Honestly, Madam Chair, it's a question I hadn't considered. Your intent was to get a COVID test, but you didn't qualify, so they didn't give you one. That's a great example of one that might very well come back before this board. So we know that.
I mean, but taking the letter, literally, it wouldn't be covered.
Correct. If I was going to read that one today just off the cuff, right, I would say that's not there because they never did the test.
Right.
So your intent and your desire.
That's the bar. They have to have done the test.
Correct.
Okay.
Okay, and let me continue this because I'm going to move it into another area. So FYI, I'm going to ask you to retroactively approve 100% of the test, and any associated charges, regardless of where they get the test done, will be covered, right? The second element to that is on teledoc services, okay? And teledoc, the same things about what can be waived and what cannot be waived. So apply to high deductible health plans. And what they're saying is that you can waive costs on the high deductible health plan for teledoc services to seek COVID testing assistance. And I put that qualifier in there because they don't have the ability on teledoc to actually administer the test. What they can do for you is walk you through the checklist. If you meet the criteria for testing, they can then refer you to an appropriate source and further coordinate with community health departments to make sure that you're recorded and you get the testing. Okay, those tests can now be paid in the high deductible health plan with no member cost sharing, period. That's easy, okay? And the reason for that is logical. Teledoc or telemedicine at any level is a great pre-screening tool to keep people from going into ERs where everybody's coughing and you have a stew pot of disease. Good thing. Flaw, the telemedicine providers cannot break out today only COVID-related charges. Their billing systems were not built to accommodate it. So we know there's legislation from council for one of our pools. There's legislation being considered nationally. It is not here yet. That will allow a temporary suspension of all teledoc cost shares on high deductible health plans. Okay?
And
it's not in effect today. Mike?
Madam Chairman, I and this is Taryn, aren't we contemplating removing fees from the teledoc service to encourage people to utilize it, or am I thinking about something else?
You are partially correct, Madam Chair. Mike, you're partially correct, because we lowered the copay share, cost share on the EPO last year to 10, okay? And this is on the high deductible health plan where our abilities to do that are limited by the Internal Revenue Code.
Okay, thank you, Madam Chairman.
So to finish the thought, so what the feds have already said is it's okay to waive the cost share for COVID testing on high deductible health plans, okay? The challenge we have is that the billing systems for telemedicine, for teledoc, do not have that capability today. So what I'm recommending, and it's one that, again, I'm glad Ryan's here, but what I'm recommending, and we've done this with other clients, is suspend all all cost share elements on the high deductible health plan, all of them, until June 30th, so that people who can go and get telemedicine services so they don't have to congregate, those will include the COVID testings, but recognize that should you elect to do that, we are ahead of where the IRS is today. I do not see a practical alternative because the billing systems don't accommodate it, and we have a mandate to make telemedicine no cost to participants for COVID. So I don't have a workaround other than to say, if you read the spirit of the law, the intent is to avoid having people congregate in places like physicians' offices, urgent cares, and emergency rooms. I think this makes sense to do. So my recommendation is waive the waive the cost pays for telemedicine on both the EPO and the high deductible health plan until June 30th.
Okay. Any questions? Go ahead.
Madam Chair. Retroactive to what date are we looking at?
I believe in this case, I have to check with Rick. I believe on this one, it's March 6th.
So March 6th through June 30th.
Through June 30th.
And that would include both of our plans.
Correct. Be on the EPO and on the high deductible health plan.
But if somebody's on EPO, it's an automatic. It already does it, correct? Or
The
actually,
EPO,
there's a $10 pay.
It's a $10 on the EPO today.
But the higher deductible, then they would have to go through Jade or you? Am I understanding that correctly?
No, they would not. We would just, for the high deductible health plan, it would be the same effective date. I think it's $40 today or $45? It's 40 today. So we would waive those retroactive for any services they've gotten and do both of those until June 30th.
Okay, but if you're calling teledoc they're telling you there's a fee. So is that refunded or?
It would be refunded. Anything retroactively would be refunded to the employees. So when we did the retroactive.
Thank you.
Madam Chairman, if they're going to be refunded to employees, the employees will apply for the refund, or it's automatic?
We'll work with the vendors to automatically do it.
Thank you.
And then there was one other last one is for managing expectations. You'll note in the reports yesterday that until now, callback times for Teladoc have been under 20 minutes. We know they are now over an hour, and in some cases approaching 2 hours. So again, relative to an ER, that's great, but just again, we want to make sure that people go, hey, what the heck, it's taken 2 hours to get a call back. It's going to be reality because all of these telemedicine systems are being swamped nationally.
Okay. I have a question, and it's a little unrelated, but still related to telemedicine. Maybe we talked about this yesterday. I honestly don't remember, but during this period, this unprecedented period, I understand all this stuff, but the federal government now allows doctors who do telemedicine to bill at their in-facility rate. Is that supposed to go on? Will that be over when this state of emergency is over? Is that how it's going to be from now on in?
It's all of these are seen, what the current status is today is all of these, because they're overriding plan provisions, right? All of these are seen as temporary measures.
But I don't know if that's true, because I know that doctors are changing over to telemedicine only and have invested a lot of money because they can bill it. Can you look into that, please? Because one of the reasons that we encourage telemedicine is not just it's better sometimes for the employee. Now it's so you don't congregate, but it's because it's a less expensive thing for the trust. But I think it's gonna stay that way.
But, Madam Chair, at the risk of sounding glib, anytime the federal government gets involved in benefits, I keep hearing, if you like your plan, you can keep it. So what I'm hearing is it's temporary, but I will check.
I think the doctors have been lobbying this for a long time.
Okay.
And I think it's going to stay.
Today, what I'll tell you, the way that works today, just for information purposes, with Teladoc and Blue Cross, their contracts drive it today, right? So unless the feds essentially says all those contracts are void, they're going to go today. And that's what the action does. The action what you're discussing is a temporary voiding of those contracts, just as it is your summary plan description. So the question is whether or not they make it permanent.
Okay. Waive all cost shares for COVID testing regardless of the source. Doctors, offices, urgent care, and et cetera for both EPO and HP, and both in and out of networks through June 30th, 2020. Will leave all other applicable cost shares in place for the location of testing. Waive all cost shares for Teladoc services for both EPO and HP, retroactive from March 6th through June 30th, 2020. Authorize Ken Cunningham and or Jade Hunga to work with ECA to execute any documents or paperwork necessary to implement these changes with Meritain and Teladoc.
Got it.
I'll second that for purposes of discussion, because I have one last question. You answered it, but I forgot, probably. If somebody does Teladoc and they go through that checklist, the COVID checklist, and Teladoc says, oh, you do need to be tested, they can't test, so they send them to, I assume, ER. And then is everything covered then as well?
It is.
Thank you.
The motion is second. All in favor?
Aye.
Aye.
Opposed?
Aye.
The financial impact modeling. Okay, Madam Chair, trustees, this is not an action item. This is us anticipating questions on the trust's ability to weather whatever may come from this COVID-related event. I'm going to caution you here because we use different numbers than finance uses, and that's based on the amounts of money that the county is crediting back and forth. I was listening to Coral. I keep wanting to say Jade, but I was listening to Coral. Either way, the outcome is essentially going to be the same. So this is a memo that would probably make your eyeballs roll around in your head, but it walks through the way the reinsurance contract works today. It runs through what we understand from open sources as to who our highest vulnerabilities are, and then it runs the math. And let me just walk through that. So the assumptions on COVID today, recognize everything I'm about to say, consider evolving, right, is that people who are over 60 who have underlying medical conditions that make them somewhat vulnerable is the population most highly at risk. We know that the average age of Mojave County's workforce is about 46, okay, just on the workforce side. So we've got a fair number of people that are going to be over the age of 60. And if you remember any of the information from yesterday's presentations, we have a high number of diabetics, we have a high number of people on coronary medications, we have a number of people actively treating for cancer or who have done so. So we have within Mojave County's population some portion of a population that would be considered vulnerable. That's significant because if the disease progression at other areas are seen at the same relative levels, we could expect a substantially different outcome than was projected by the actuary. Okay? And to put it in a word picture, every one of us, when we get in our car and we drive somewhere, our expected outcome is we get there safely. But we don't always get there. We have car wrecks along the way. So what this looks at is we didn't budget for this thing. So if things get serious, we're going to have to fall back on the trust's financial position to weather the storm, okay? Money-wise, we're doing great. We got plenty of cash, okay? So what's going to drive that conversation then is the terms of the reinsurance contract in place at the time the claims appear, okay? So what I did is I modeled the trust's current financial position based on the terms of the current reinsurance contract. And there's a funding gap that's in there within that layer that we retain. And the way that works is Chris, the actuary, does a projection that says, here's what I expect the claims to be. And he did that before COVID hit the scene. We then have a reinsurance contract in place that has a thing called an aggregate stop loss in place. And there's a gap every year in the funding from the expected claims to where that reinsurance contract starts to pay, okay? And that's why we build up surplus, because it's always there. In all candor, that aggregate stop loss is never expected to pay a dime, and in the history of the trust, it never has, period, okay? So what they say, they set the attachment point of that ag at 125% of the expected claim. So there's a 25% corridor in there. And the way you fund that gap is off of surplus, the money we've got in the bank, okay? So I ran that modeling based on our numbers, and if you look on page 2 of your memo, I took a clip of the spreadsheet where I did my work, and I did it conservatively. Frankly, we've had a heck of a good year. This is what it looks like. You've got that in front of you. We've had a heck of a good year. I assumed that we would not continue, and if anybody needs it, let me know. I'll give it to you. Give you another copy. Okay. But I figured we'd only wind up at 70% of what our projections are on an actual spend basis. So what I was assuming in that is that we would start to see COVID claims begin to be paid late in May or early in June. So it would kind of gap over the year. And it's back of the envelope, but here's what I think is going to happen. And then how would that funding gap be? Now, using my numbers, okay, we would be in a position where we would have just shy of $17 million in surplus. So that's cash less IBNR, okay? And that funding gap in the current year would be $2.6 million. So we would draw down our surplus of just under 17 million by about 2.6, and that would leave 14 million. Now, the lowest number I heard in Coral's presentation was 9 million. So let's take that on the far end. We have 9 million available. We take 2.6 out of that. So we've got 6.4 million left. So here's what that really means to you. Based on the current reinsurance contract, okay, and there's no way in heck that number is going to happen this year. Based on the current reinsurance contract, we still have enough money in the bank that we can get hit again next year, and we would still have more than enough money to keep the trust financially solvent. And what that means is to continue to pay the claims that come through for all the employees and dependents who are relying on it to get their benefits paid. The variable that's in here is that now everybody knows COVID's there, including our reinsurance carriers. So Amanda and I are going to be starting to renegotiate for next year. We have built into the budget a 25% increase in the premiums, right, because of the known cases that may or may not prove adequate because we didn't know about COVID, and we're going to be negotiating that attachment point of the aggregate for next year. It will be a hard negotiation. Those stop-loss carriers know it too, so we don't know where it's going to wind up. But in my mind, I believe at the end of the day, we will, even with those contract negotiations, expecting them to be less favorable than they are, I believe the trust will be in a very good position to weather the storm for the remainder of this year and through the end of next year because of the surplus that's in the bank. So long story short, we can sleep at night. Doesn't mean we're going to have a great bank account when this is done, right? But because of what you're seeing here, I know, Susie, I know you're new and there's other trustees, but what you're seeing in here is for years, the trust and the county staff have made tough calls to fund it correctly, right? And you always say why, because you don't know what's coming down the road. Well, what's coming down the road has come down the road and it's here. So the solvency that you guys have built and your predecessors have built over the years, now that it's here is what we're going to draw down. So it's good news.
Okay. Madam Chairman, I do have a question. I understand that you, the insurance company, and the providers are doing all this modeling right now of what's going to be next year. But when the time comes to renegotiate our contract next year, I understand you'll use the modeling that's being done right now, but do you actually go by actual expenses to be able to get a closer feel of what our expenses would be by next year?
Yeah, Madam Chair, Susie, we do. Because what actually happens, I think that's what's going to be different. In prior years, and Amanda actually does all the legwork in the background on it, what happens is there's a ton of data that gets together, but it's the actual data. It's here's what we paid through some month. And a lot of times what they'll let us do in good years when they're competitive is we can bind the reinsurance at the end of March or April, right? Because they're like, okay, they just want to get it on their books for July 1. What we expect to have happen is these negotiations will go into June this year. And it may literally get down to the end of June because they're going to want claims through the absolute last second because they're not in business to lose money. So they're going to want to know how many large cases do we have, how many people do we have on ventilators, whatever. They're going to want to know. So we think this one's going to get all the way down to the very end to negotiate. And I will tell you that last year we were seeing the market get tough before this hit. In one of our longest term clients, a client we've had since 1994, we had one company willing to offer a renewal. So we're hoping this year that we will have multiple companies, but at the end of the day, we're going to need just one to come in.
Madam Chairman, I have one more question. Do we anticipate anything from the stimulus that has been passed to assist us with any of this medically related expenses in the area?
We are not aware of anything yet. That doesn't mean it's there.
Yeah.
But because, Madam Chair, Susie, all we're doing is trying to get everybody through the year at this point.
Yeah.
We're aware they're talking about a lot. We have not seen any details on anything that might pay, even, for example, the cost of all these COVID waivers. We have not seen anything yet.
Okay, thank you.
I actually think that I have seen something, but when it comes to light, because they haven't voted, it's just a vote today.
I think they're doing a roll call today, right? Is that what I'm reading?
I'm not really sure. It changes every minute. But we'll be made aware of any relief that we get from the federal government and the state, because I know that they're taking this into consideration too, as they should.
You can always hope. I mean, it seems to me what I'm reading is the printing presses are running. The Benjamins are being printed,
Yep.
so it's where they're going to wind up.
Yeah, we don't want to go there. Okay.
Madam Chair. If it is possible that we can be reimbursed for that, do you track COVID, or can you track COVID-related illnesses or payments, payouts, so that that number could be provided to the county for reimbursement, if that's a possibility? So
Yes.
you
So,
have a
Madam
way to
Chair
track
Berlin,
just
the
those.
question is, are COVID-related costs being tracked? The answer is yes. The feds have issued 2 new codes to the claims administrators, which is not ECA. We'll compile it, but it's Meritain that actually pays the claim. So we know they've issued 2 new codes already to track it. So to the degree that anything might be available, we'll be able to track some portion of it. The only wrinkle I always want to put in there, Madam Chair Verlin, is, again, it's going to be those weird ones, Verlin, where somebody comes in for something else, like a car accident or whatever, and turns up positive. I don't know how that's all going to shake out, but I can tell you that we've done things that were complex before with TPAs and been able to do it.
Okay. So where are we at now?
No motion on this.
No motion. This was informational? Okay, and now we are at
The reinsurance one.
the 11. Discussion, consideration of, and possible action regarding reinsurance renewal process.
Okay, so Madam Chair, this is an annual one. It's just going to have a little more import today, and it's what I was just alluding to or referencing to. So what happens every year is the trust grants authority for us to work with Ken to bind the reinsurance, and then we come back to you to gain approval. So we're asking for that again.
Okay.
And with everything that I just said before, we're expecting it to be an 11th hour thing. This one
Okay.
does require a vote.
Okay, so the motion is to, motion to approve ECA to work with Ken Cunningham, Human Resources Director, to negotiate and bind the reinsurance renewal effective July 1st, 2020. Okay,
I'll make that motion.
okay. Motion second, all in favor?
Aye.
Opposed? Motion carries. Okay, and now we're going back to 2.
We're going to go back. I think what we should do, Madam Chair, is we have a memo which is for us is vendor renewals. For us, it's item 7. And then we would go,
Okay, so
go into the budget, which is item 2.
Okay, what about 8? So 7, 8, and then 2?
And 8 and 2 are together.
Sam Scamardo.
Has left the
Do
conference.
7, and then we'll roll into 8.
Okay,
And 8 and 2 are essentially the same.
okay.
2 was a leftover from yesterday in case we didn't get to it.
Okay, so 7 is discussion, consideration of, and possible action regarding EBT vendor renewals effective July 1st, 2020.
What page is that?
And where is that? Where is that in our book? Back in, there's an 8, 7, 8.
What tab would that be? Yeah, what tab?
Oh, you want me to?
You want to do it?
Erin, do you know the tab we're on now? This is making my brain hurt.
It's, the regarding line is administrative vendor contract renewal offerings.
Yeah,
It
Or what
would,
page?
on this agenda, it would have been, so it's 7 here, so maybe 6 on your agenda if you took off all the public. Right, we have different
Yeah, but we're
It's this sheet here.
319.
What's it called?
319 is different.
Now I get what's
I can't find it.
No, this is the minutes. This is the trust minutes. I don't think we're approving the trust minutes.
So this is the trust meeting.
Cool.
Right here, so we're right here.
I'm
so
lost.
You're under 17.
I'm lost too. I can't, it's like the only one I can't find.
Maybe under.
No, tab 18 is COVID.
So it's on the back of the, AD&D memo, life and AD&D. It's on the back page of the life and AD&D, so it's right here.
Right after Oaks.
Oaks.
We could do dental claims again.
Brush your teeth. So there's a dental.
Tab 17 or tab 3. If you do the 2-day one,
356.
Everybody got it now? No worries, Ken.
Mm-mm.
Okay, got it?
No. Which tab?
Page 356. Do you have a tab 7?
This is my 356.
Well, I'm for the short term. Or 17, yeah. And it's
Okay, thank you. Yes. Thank you. Thanks.
So these 5 items are only the contracts that will be new to the upcoming plan year, that will require Ken to sign, or Hildy, Madam Chairperson. So what it is Meritain, their part of theirs is up for renewal. Their Aetna fee was up for renewal as of June 30th. However, they are holding that for the Aetna network at $7.50 per employee per month. And then also Teladoc, they're also holding that fee at $1.55 per employee per month. American Health Group, they're just out of a 3-year rate renewal. They offered another 3-year rate renewal. They're increasing their per employee per month from $1.95 to $2. ECA, we're offering for consulting a 3-year rate guarantee. The first year, it will continue at $55,000 per year. The next year will be, we're requesting a $5,000 increase at $60,000, and then the following year will be $60,000 again. For the wellness consultation fee, right now it's at $650. It's another 3-year contract of $650 for the 2021 plan year, $650 for the 21-22 plan year, and then $7 per employee per month for the 22-23 plan year. And then for Buck Consultants, they're offering a 3-year rate proposal, increasing their fee from $21,000 to $22,000 for 3 years.
Madam
Any
Chairman.
questions? Yeah.
I'm sorry. Go ahead, Susie.
Madam Chairman, since I'm new in the process, I'd like to clarify the process a little bit. Based on this item, we're actually giving the authority for Ken and Erin to negotiate or to sign these contracts. Now, is this going to come back to the board, or we're giving you the authority and it goes from there?
You give the authority, because what these are, is, Madam Chair, Susie, is extensions of the existing contract.
Okay.
So it's basically to sign the amendment to the existing contract.
All right.
And it would actually be done, I don't think Ken signs these. I think these have to go back to the chair of the trust.
Now, does it go back to the entire trustee or just?
No, they're just signed.
The trust approves it, and then I just sign.
Oh, he does sign it, okay.
The board approves the contract changes.
What we're doing right now is approving the contract change. We're giving authority to Ken to sign the documents.
What you said.
Exactly. Now, it doesn't have to go back to the trust, right?
Correct.
Okay. Now, are these one-year contracts? Now, the rates are 3-year guarantee, but these are actually one-year contracts?
Yeah, these are actually one-year contracts, and then there's a provision in there where, for cancellation at the end of any 1 year. So essentially what all of these do, again, kind of like with the life insurance contract, is they lock the vendor in. So they're locked into those rates, with the trust having an option to cancel any one of them at the end of each fiscal year.
Okay. But every fiscal year, we still renew the contract?
Yep.
Okay. Thank you.
Okay? Anything else? Okay, I need a motion. Sure.
Still got, no, I'm going to do that. I got it right here, Verlene. It's in the budget. It's in the budget and rates.
This is, I need a motion to approve the vendor contracts as presented and authorize ECA to work with Ken Cunningham, Human Resources Director, to review contracts and sign approved contracts effective July 1st, 2020.
So moved.
All in favor?
Aye.
Opposed? Motion carries. All right, now... Next tab.
That's going to add.
Is discussion, consideration of possible action regarding 2020 to 2021 MCEBT budget benefit changes and rates.
So this memo, I apologize. Being we moved it, we didn't know if we were going to do this portion yesterday or today. This actual memo is part of yesterday's work session. So it should be the very last memo, and it's the regarding line is 2021 budget development process. So it'll be part of yesterday's packet in your book.
No.
13. Tab 13.
Yes.
Yeah, 305.
Oh, page 305.
After tab 13.
So you're going to read through the...
Go
ahead.
Walk them through what we've got.
So in regards to this memo, we can do it a couple of different ways. I can just go through. I can go through and I can highlight the changes if you have already reviewed the memo, or I can go line item by line item per vendor.
What's your pleasure, board? Okay, let's go with the line item.
Okay.
He just cost me $1.
I told you. Okay, so initially, where it's stating the draft budget, this is where ECA makes their recommendation of what we feel would best benefit the trust. So it's stating here that, as the actuary stated, a 0% increase for medical and RX and also the dental. And then the insurance premiums, as we'll go through and as you just approved for the contracts that were up for renewal. And then also implementing the pre-disease management through Livongo for the whole person, and covering preventative at 100% on the dental low plan. And so the dental low plan at this point, it's only covered at 80%. And as it shows, between what Delta Dental was stating and the campaign, it's really low that people are going in and getting their preventative. So we thought that it would be beneficial to cover that at 100% for people to go in and get their teeth cleaned. And then it also states that with these changes, the option, it's a 1.35% increase. But we made a couple of changes yesterday to where we decreased the professional line item, and then we also took the the EAP rate from the $2.26 back down to the $1.44. And so actually, right now, the budget is showing at a 0.5% increase. And we'll go through that budget here in just one moment. So that is what we're recommending for the budget changes. If you go to the next page, it starts with the specific stop loss. So what we're recommending there is a 25% increase, which would increase your premiums to $61.93 for the employee and a $172.63 for the family rate. This is an annual impact of approximately $271,000 for the year. The aggregate stop loss, we're assuming approximately a 5% increase from 220 to 231, and the impact for that is much less at 1,205. And then again, the employee assistance program, I took that fee back down from the 226 to the 144 as stated yesterday. She stated she would hold that rate, so there wouldn't be an increase to that line item.
Okay, before you go on, but we're going to go right through each of these programs. Vote on it. Because we need to talk about that EAP.
Right, and so that'll be when I bring up the budget,
Okay.
We'll go through and build that budget. The group life and accidental death and dismemberment, right now it is through the standard, and trustees heard the awarding of contract to Securian, and so that will be part of the budget building as well when we reduced that already from the budget, so that's showing about $150,000 decrease for this plan year. Short-term disability, with making those changes, moving over from standard to Securian, we're looking at about a $31,000 decrease. And then moving on to the administration fees, Meritain, the third-party claims administrator, their administration fee per employee per month is increasing from $15.27 to $15.58. That's the only increase we're seeing with their admin fees. They do administer the FSA, the Aetna Network, and Teladoc, but those rates are not increasing. And so we're looking at approximately a $3,000 increase for Meritain. American Health Group, again, they're ending a 3-year rate renewal. They're asking for a per employee per month increase from $1.95 to $2, which is an annual financial impact of $548. Blue Cross Blue Shield, right now the per employee per month rate is $16. The 2021 plan year, it will increase to $16.75, which is an estimated impact of approximately $8,000. Delta Dental, they're in the 4th year of a 5-year rate contract, and so their admin fees are increasing for both plans. Both plans mirror each other. $2.07 for the employee will be increasing to $2.20. Employee plus spouse from $4.24 to $4.52. Employee children, $4.85 to $5.17. And then employee plus family, $6.84 to $7.28. So we're seeing a small increase there as well, which is an annual financial impact of approximately $2,000. Navitus, they're in their 2nd year of a 3-year contract. The per member per month fee is going to increase from $2.15 to $2.21. We're showing a decrease of $1,000 on that. And really how this works, I do understand that it's an increase of pennies, but we look at the overall for the year of what was budgeted and what was utilized. And when it's based off of per member, it's we have to bring the numbers back to calculate it into a per employee per month rate. And so that's why it's showing the $1,000 decrease. ECA, again, we're ending we're at the end of a 3-year contract. We're holding our rate from this year of $55,000 to $55,000 again next year. For the wellness consulting, for the per employee per month, right now it's at $6.50. We're holding it again for next year, the 2021 plan year, $6.50. Case management, this is by member who utilizes this service. So again, we look at the utilization for the past couple of years. And so we're showing that based off of utilization for the past 2 years, the plan's utilized about $24,000 is what they've paid out. And so we decreased that line item by about $1,000. Home and case management fees, this is a breakout for the mental health and substance abuse. To be honest, I don't know on this line item. We haven't been billed for anybody. I don't know if anybody has utilized this service. And so we just left it at the $5,000. The Livongo program is doing very well. Participation has increased significantly. And so we added $21,000 to that line item. Wellness program fees, that's a flat $20,000 that's budgeted in there. The professional fees, we get direction from the staff. They give us what is utilized in your internal budget, but then we added the $22,000 for the actuary. For personnel services, we did budget the $353,000, but we have already decreased it back to the $306,000 as directed by staff, and so that is what's showing in the budget at this point in time. And then the office miscellaneous expenses, this one we have budgeted at $56,000, which is a decrease of $224,000. And how that works is after we negotiate the stop loss, any additional funds that weren't utilized in that line item, we move it back into the miscellaneous line item. So that's where that decrease came from, because we pulled those dollars just basically went back into your surplus.
Madam Chair.
Yes.
Personnel services increase?
The personnel services, we took it back down to the $306,000. Initially, when we received the budget, we were asked to increase it by $46,000, but then we were asked to take it back down to the $306,000 again.
Can I ask a question about the teledoc for Meritain? So that's per employee per month for the utilization, and what does that cover? And why is there a fee for that?
So the $1.55 is the administration fee through for the service, but there is the cost share of the consult itself, so it's 2 separate fees. So the EPO, it's a $40 consult fee, but only $10 is charged to the employee. $30 is paid for by the trust. And then with the high deductible health plan, it's $40 for the employee till they meet their deductible, and then the plan pays 100%. So that $1.55 is the admin fee to administer that program.
Sam.
It joined the conference.
It's not going up. It's holding at the $1.55.
Okay. Anyone else have a question?
Madam Chairman?
Yes.
It appears like based on your presentation, there are changes based on the memo that's attached in here. So do we see something with those final numbers that you have?
Yeah.
So we could at least see it?
And that's
or
the
is that
next
going to be
stage.
reflected in the
That's the
budget
next
that we're
step.
going to be approving?
So, Madam Chair, Susie, that's the next stage. What Amanda's going to pull up is an interactive that we have. That's the budget. And it actually goes through, what she just read to you is everything that's already incorporated in there. In other words, all those charges have already been built into the budget. This is basically a disclosure document that gives you what our assumptions are on the fixed cost portion of the budget. So what all the vendors are being paid and how that breaks out into the components that build into the rate. What we're going to move into next, right, is we're going to go into the variable elements. Berlin, I got you here, okay, but the staff recommendations that will impact the rates, and that's the actual benefit design. So that's what Amanda's moving into here. And for that lead-in, what I'd like to do is walk through what you've already done, because that's built in here, and then we'll talk about the 4 items that we have that are remaining for you to make a decision on, okay? So if I can, the 2 that are done is that you awarded the contract for the life and the short-term disability to Securian. So that's done, and we assumed you would. That's been built into the budget. So those dollars have essentially been removed from the overall costs for the budget. The second thing that was done was the 100% charges for all of the preventative care with Teladoc and with medicine. So our remaining items that we're going to walk through in sequence, the ones that we knew about in Berlin, I'll walk through on yours, which we did not have budgeted, okay, but we'll figure out. So staff records, the items up for consideration is is on the low dental plan, making preventative care 100%. Okay, it's on the high plan, it's not on the low plan. So moving that to 100% of preventative. So basically, we want people going in and getting preventative care. And if you remember from yesterday's presentation, and for some of you have been here for several years, for whatever reason, we have a very large population of people that don't seek preventative dental care. Preventative dental links into cardiac and diabetes and all these other things, so we see it as one that if we can remove a cost barrier and then do these outreaches to get people to go into the dentist and get their oral hygiene, that we'll be better off. So staff recommendation number 1 is increase the preventative benefit on the dental to 100%. Secondly, on the EAP, we had a conversation yesterday. After that discussion about whether or not the EAP is worth it, we huddled with Ken and Jade, and what the recommendation is going to be is to non-renew the current EAP provider for the current year, to leave the dollars in place in the budget, and then to absorb 2 costs that the sheriff's office is currently using or is proposing to use. One is, and Ken and Jade will jump in, but they've got essentially a sex crimes unit over there where the sheriff has implemented a once a year sit down with a psychologist to make sure you're still okay program. We estimate the cost of that to be about $4,000 a year. It's an estimate. We haven't done it, so we don't know. And then the second part is partially covered by, theoretically available in the current EAP program, but he has a vendor for critical incident counseling that is required under law. He has a vendor he's using in Prescott, and to absorb the costs of those critical incident type counseling sessions. Now, Ken and I had a conversation about this yesterday, and I've had conversations down at ASIP on this. This is the intent of this one. It's kind of a funky one. Okay, you can budget it however you want to budget it, but you're going to have to pay it under state law somewhere, or the county is. But the intent of this is to keep people that are having post-traumatic stress disorder type events out of the workers' comp system. So it's offering a benefit. So it is, in my mind, it is an appropriate one to budget into the benefit trust. So what we would do is absorb those 2 costs from the sheriff's office using the existing budget. They are both unknowns. Okay, so we're just saying leave the money in there, let's see how it plays out. And then as pertains to employee assistance, the remaining services, employee assistance and psych and substance abuse counseling services, we will work with the HR staff this year. We will drop the EAP for the current year for all other employees, but we will work with HR staff and do an RFP to reintroduce the benefit next year in a much more structured fashion. So we'll go out to RFP, see if we can restructure what's there to address the concerns with the EAP and bring back a recommendation for the 21-22 plan year. Madam Chair?
What is in the EAP that's different than what employees can get just from their regular benefits?
The difference with the EAP is that it's no cost to the employee. So if they go, and it includes people who are non-prescribers. So it's lower level counseling at no cost, and its intent is to be, on the EAP side, for more transient events, divorces, kids, financial, a bunch of services that are frankly are not typically included in the medical plan, and it does it at no cost to them. So it's kind of a fallback, a first source, versus going into the health plan where you have cost shares.
And how much has it been utilized by our employees?
Been very low level utilization here. So again, it's an optional one. I would tell you that we tend to advocate for them because they tend to be low cost, and they give you a vehicle that's a fixed cost to the plan outside of the medical.
Go ahead.
I have a question. Can we give a benefit just to the sheriffs, detectives, and those who are involved in these critical incidents that's not available to other people?
Madam Chairman, there's a push in the legislature, and you all may or may not be aware of it, to include the PTSD as workers' comp. And ASAP's been trying to fight it, and also working with Aaron. There's been conversations between Bill Hardy and Aaron, to find ways to protect the county, because if the legislature does approve including allowing the inclusion of PTSD issues or those type of mental health issues in workers' comp, it's going to be incredibly expensive, and it's going to be millions to Mojave County. So it could bankrupt us very easily. So it's my understanding what you're proposing provides us with a level of protection to try to keep it out of the workers' comp insurance area. And that's what you just explained.
Madam Chair, Mike, that's correct.
So it's very important to us, I think, for our future. Even though I don't have my arms fully wrapped around it, and I don't know if anybody does, but it's come very close to being a reality in the legislature recently, and they continue to push for it. I think the League of Cities was on board for supporting that legislative drive, and I'm not sure what the status is now, but it's probably still on the table. Thank you, Madam Chairman.
Madam Chair?
Yeah.
And I understand that, Mike. But how do we give just the sheriff in this plan that you're proposing when we might have a PTSD case with a county attorney who has to prosecute a horrific crime?
Madam Chairman, Berlin, I see your point. I didn't understand that this particular coverage would just target the sheriff's office. I would have to agree with Berlin that PTSD is PTSD. If it's something that's been generated through the workforce, through activities, then it should be covered. Is everything else excluded?
The intent of this one, Madam Chair, Mike, the intent of this one is to conform with that House Bill 2350. So if they were covered under that House Bill 2350, the intent would be to have those costs shift into the trust for the current, we're only budgeting for the current year, so for the current year. So to the degree that a prosecutor or staff would be involved, or a dispatcher, or whoever in the county staff, if they were covered under House Bill 2350, as in force today, then the intent would be they would be eligible. So I just don't know how that works in the prosecutor's office, Mike.
Madam Chairman, I just want to understand the proposal that you have. It appears like you are proposing, or based on your discussion with HR, to cancel the EAP program, but retain the budget. And that budget will be used for other purposes, like what you have just discussed. My concern is, and I know we talked about the utilization rate of the program, whether it's being used by a lot of people or not, but when it was established, and it's been established a long time ago, it was intended to help employees with those levels that you're talking about. Those circumstances that may affect them in the workplace. I seem not to agree as a trustee to use that money that's intended for that program for another group of employees with other types of things that we need to address. And I understand that we need to address the other types of situations that we have, but taking this money away from EAP and canceling the program, I think we need to discuss that more, Madam Chairman.
Okay.
In terms of its utilization and how it's, I mean, you are more in the front line of how it's being utilized by the employees and how many, I understand there's 44 people based on the report that yesterday that have used it.
Well, I'm not quite sure on the number, but we're paying for a service that our employees can't use because there was one provider in Bullhead City, 11
so
in
it's a
Lake
provider
Havasu,
issue.
and then 4 providers in Kingman. And then our employees are calling and they cannot get in. And what the lady from the Holman Group said yesterday was also is some of those providers are not taking new patients. Right. So even if they have those 11 providers, we can't get our employees in. So we're paying that $144. Was that what it was? $1.44 per member for a service that they can't provide. That's why we were recommending that we could use our money somewhere else. And it won't use near as much money as what we're paying, because that's what, $2,400 a month. Right now, for the sheriff's office, the detectives, there's 12 of them, and for an annual meeting with the psychologist was $100, and then the post-traumatic stress started at $500 if that occurred, which we already have a contract with. And the one we have a contract with is the only post-certified person in our area. So that's why we won't be using all that money, and then that money stays in the trust, and if it's not used, it comes back to the trust to decide how to use it for the following year.
Can I ask a question? So if this is a service that is only used by the Sheriff's Department, why doesn't it come out of their budget?
Yeah, true.
And why does the whole county have to
Madam
pay?
Chairman, Sheriff's budget is general fund. So it doesn't really matter, the county's going to pay one way or the other.
Well, no, I understand that, but, it appears in the trust itself that we are favoring one group over another. So if it's coming anyway, why can't it just be worked into the sheriff's budget?
Well, and Madam Chairman, if I can, I believe, and I'd have to defer to Aaron. This trust is created to do certain things by statute, and it's to self-insure Mojave County. And the county itself doesn't purchase insurance. If you ask the sheriff to pay for it, that would almost take it out of the actual structured process that we for the way we purchase insurance and do business, to cover our employees. So it would be like saying, why, instead of allowing our employees in the county to contribute to this, to all the insurance of the county, let's have Public Works pay for dental, or some component.
That's not a good analogy, because everyone uses dental. Yes.
Just wondering if the critical incident contract or vendor that the sheriff uses, if the EAP program, instead of using that money, if that could be expanded to include all PTSD incidents that a county employee has on the job, whether it's the county attorney's office. And maybe Mr. Esplin can tell us if HB 2502 is limited to only sheriffs, or if that would include somebody like the county attorney who's prosecuting, or a clerk who's doing it, or a juvenile detention officer, or a person at the treasurer's office if they get held up or something?
Ma'am, my understanding is with this contract, because it's law enforcement, he specializes in law enforcement. So I'm not sure if he has a wider practice in that. He's a one-man office, and he currently does just do law enforcement for us. Whether that's a detention officer, I think your people from probation stuff would qualify under the law enforcement. But
No.
Madam Chairman, I've got it up here. It says, notwithstanding any other law, the state or a political subdivision of the state shall establish a program to provide public safety employees. So I'm sure public safety employees are defined someplace, but to me that is fairly self-explanatory. Do you know of any other exceptions? I'm sorry, we've got the attorney here.
Yeah, so just following off of what County Manager Hendricks stated, public safety employee means an individual who is a member of the Public Safety Personnel Retirement System, so PSPRS members, or Correction Officer Retirement Plan. It also includes probation officers, surveillance officer, or juvenile detention officers employed by the state. So it would be those who are PSPRS eligible, as well as probation officers. So it would not be the county attorney's office. We don't get.
But Madam Chairman, I think to Verlin's point, we can insure anything, correct?
Yeah.
So if we so chose as a board to expand that to all PST cases, then we could insure that, correct?
We could, Mike. Yeah. And Madam Chair, if I could just intervene, because I know we're going to wind up getting ourselves lost in here. So let me clarify what the scope of services is, okay? And what this really reflects at the end of the day is what Ken said. We have a vendor issue here, not really a contract issue. So we have a vendor whose network is not adequate, okay? When we put this contract together several years ago, it actually includes a lot of what you're talking about, Verlin. It has three components to it. It has the basic EAP services, which is the low-level stuff we're talking about. It has case management, and this one you'll remember from last year because it was kind of controversial for the chair when we restructured the psych benefits last year, but it includes case management to help them. That's billed hourly, and then it includes this law enforcement component, which we put in several years ago when that bill first passed. So all three of those are in there, but frankly, the vendor's not working. Okay, so, and on your critical incident stuff, Verlin, for employees, the basic EAP includes a section for critical incident for anybody. So they can, if you have a situation like that, a holdup, the exact scenario you used, workplace violence situation, all of those vendors have a component typically where they'll bring a team in to do debriefing, okay, and to actually work with people. So it's a fairly expansive scope of services, but I want to come back and tell you what we've got is a vendor issue. So what we're doing is we're using this as a time because the county does have its obligations under 2305 to a range of specific people. The sheriff has taken that a little bit further, which I would laud him for doing for these people who deal with sex crimes. So since we've got the budget and it's appropriately in the benefits item, whether you put it in the county somewhere else, but it's appropriately in here, and it's the type of services that this whole EAP contract we did was intended to address. I get it. It looks a little weird, but it's consistent with what we've been attempting to do, which is to find the benefits solution to a thing that's got elements of both work and life. And so what we're proposing, again, however you get there, is we'll absorb those costs because they're there. It's consistent with what we've been doing. But give us a year to fix the vendor issue because, as Ken said, it's really irrelevant if they can't get in.
Right. So it's $1.44.
And we're leaving it in the budget.
Leaving it that. So just as a aside, so we found out yesterday that it's a vendor issue. They can't find providers, but they still wanted to raise that rate. Was that going to get us anything else or just more money?
No, I think with that, I think what you saw yesterday, Madam Chair, is the presenter changed multiple times and the CEO wound up, we didn't even know she was coming on the phone. I don't think she checked with her staff.
Okay.
That's my guess. I think she got confused and then she realized she was in trouble and just cut the fee real quick.
Yeah, exactly. That's exactly what happened.
That was my take on. I've worked with her for a number of years. I mean, good person, no arguments. But I think she got caught short yesterday.
Yeah, I think we made it clear how we felt about it. Okay. Anyone else?
Madam Chairman, just to clarify then, so the basic issue is the budget remains the same. We don't have a vendor. because we're not renewing any contract at this time. And then we can just discuss further later on how to use the money.
And we're going to take it out to RFP. The intent is to take it out to RFP and restructure the benefit. And I'm, guess here, a little bit of a guess here, but what I expect to have happen is we'll have a combination of online and in-person because there's a vendor shortage.
Yeah.
And we know there are avenues out there that emphasize this online as well as, so we'll work with Ken and Jade, kind of like we did on the life insurance. We really structured that to meet the county's specific needs. So we'll meet with them, come up with a structure we think will work better in a more connected world, and then bring that back next year for you, either for an up or down vote.
Okay, thank you.
Okay.
Okay, so that's just to clarify, Madam Chair, to move on. So what we're saying in the budget, which you're going to vote on, is we're assuming we're going to non-renew the EAP vendor, and we'll absorb those two elements from the sheriff's office in the current budget and then go to RFP, just to put that circle. That's what our recommendation is. I'm trying to pick the easy ones here so we can do. The 4 items that I think are going to require discussion is Verlin had asked a question about what the availability through Teledoc is for additional services. So we got information on adding dermatology services, which we can talk about what those costs look like, and adding psychiatry and psychology to that. And I have some cost information on that. The other 3 is the helicopter issue presented by Maritane, the copay max presented by by Navitas, and the whole person preventative thing by Livongo. Those are what I show as the remaining, and then the preventative on the dental, which we already covered. So, Madam Chair, do you have a preference for how you want me to go through those items to discuss them?
Can I interrupt you for a moment, Darren?
What? Excuse me, Sam?
Yeah, at this point in time, Madam Chairman and members of the fellow trustees and the board, and Aaron and everybody's staff included, I've got an issue, so I'm going to have to take leave of this meeting right now, and if I can get back in when this is resolved, I'll come back in. But right now, you're all doing a great job, and I just have got to take...
That's fine, Sam. Don't worry. Go take care. We'll check in later.
Bye.
Bye.
Sam
has left the conference.
Okay, so you do it the way you want to do it.
I think it would be good. Let's find out what Verlin's looking for, and then I can walk through costs, what her questions are. We can do that component, and we'll move into the other ones.
Well, I think it probably, the Teledoc and the, is an EAP type program available. And can we just switch our money over to Teledoc if we can get instant gratification or services or help through Teledoc as opposed to being on somebody's waiting list for several months perhaps, or no new patients with our EAP program now. So I know that Teledoc has expanded in their services, so I'm just wondering what other services they have out there that they provide that we don't have, and what those costs would be. And, specifically with, what EAP was supposed to provide for our employees.
Okay, so Madam Chair, so Teledoc does have, and you're just limited, your only concern is psychiatry, psychology, Verlin?
Aaron, really, whatever expanded services they provide, isn't now the time to look at that.
Okay. All right, so there's 2 additional ones that for pure medical delivery they have. So I looked at those. Dermatology is one. So they can do dermatology with your phone, basically. Okay. And that's a $75 copay is the actual charge. Okay, so if you want to, and it's going to be the same with psych. Okay, if you want to go that way, what we have to do is then there's no per employee per month charge on the admin. It's 100% that 75. So what we would do is take a look at that $75 copay, and on the EPO, we'd take a look at that and say, well, how much should the county absorb to make it consistent with specialists for any other provider? Okay, on the high deductible health plan, 100% of that 75 would be paid for by the plan. By the member. Okay, so long story short, we would just go back, we get with the actuary real quick, we would take a look at that, we'd come back with a quick recommendation on how to filter that into the plan. Okay? Secondly, on Psych, it's 35 cents per employee per month as the admin fee goes up. And then there are 4 levels of copays, or costs, let's just call it costs, okay? So for general psych counseling, it's $40 per visit. For a psychologist, it's $80 per visit. For a psychiatrist, which is a prescriber, it's $160 for the first visit, and then it is $90 per visit thereafter. So if you wanted us to pursue this as an addition to the medical plan, we would, again, here's what we would do, just real world. We can do this fairly quickly. I can't do it today, but I can come back pretty quick, okay? What we do is send that to the actuary, because we have 2 considerations. How do we charge it on the high deductible health plan versus the EPO? And then secondly, how do we do the cost share on the EPO side specifically to make sure we meet the requirements under federal law for non-discrimination? That sounds like a lot, but frankly, that's about, we'd get with him on the phone real quick, we'd double check, we'd do the conversation in about 15 or 20 minutes, he'd crunch his numbers and come back with the budget if you wanted to look into that. Okay, so it would not be done today, but we could do it fairly quickly if you wanted to consider that, and we reschedule a telephonic meeting for the trust to consider it. Okay, so as we go forward, if you want to pursue that, what I would suggest is when we get to that point of the meeting, we can go through adopted rates with an asterisk, and then we'll go back and get that ball rolling to come back with and reschedule a meeting real quick to consider it.
Okay, is that what you want?
Is that okay?
Madam Chairman? Yes. Just to follow up Verlene's question, if that is added as part of a menu of services to be taken from or to be provided by Teladoc, is that going to increase the trust's expenses for that?
Yeah,
because
absolutely.
Right now
It'll
it seems
some,
like Teladoc is billing us per employee.
It
for
will
their
have
admin.
some direct expense. Nothing in there is going to be dramatic in terms
Well,
of the cost.
the direct expenses will be with the plan and the employee.
Correct.
But I'm talking about the trust budget for the admin. Is that going to increase the admin of Teladoc if we increase the different additional services that Verlene is talking about to be part of their services to be provided?
Yeah, the short answer is yes. So there'll be, on dermatology, there's no per employee per month pure admin fee. It's just the cost of the $70 visit and how you split it between employees and the trust. So some portion, I guarantee you, will be borne by the trust, okay, on each visit, just like a doctor's office visit.
Yeah.
Right? Okay. And the same would be the case on the psychiatry side. Mm-hmm. So some portion would be borne by the employee, some portion would be done by the trust, and that's why we would get with Chris, the actuary, and he'd give us, here's what I think it's going to cost, and we convert it back and build it into the rate.
But that's in the form of a claim. But in terms of the admin fee that's being charged by Teladoc against the trust budget, it's not going to change.
It would be for psychiatry, but it's only 35 cents per employee per month. That's the fixed charge increase. Right. It's the only one in here.
Okay. Can I ask you something? So the problem with AEP was not enough providers. How is this going to be different? You're assuming that doctors will be more available by Teladoc, or they use doctors outside the area?
Yeah, that's exactly right, Madam Chair. So because the problem we have with provider availability is we're in rural Arizona. Mm-hmm. They're just not here. So what Teladoc does, as it does with the medication side or the MD side, is it's national.
Okay, very good.
So it gets you that whole thing.
Yeah, that makes sense.
And frankly, by definition, if they're contracting with Teladoc and they're accepting calls, they're accepting patients. It will not replace the EAP, because the EAP has a broader range of lower level services than this. For higher level services like psychiatry prescribers, this will give them access to an expanded number of providers.
All right, now I'm really confused, because you're talking about psychiatrists. What about therapists? Just somebody who needs your, common sessions, someone to talk to.
We'll give you a higher number of those outside of the area, but it won't give you this, like Verlene had raised the question, Madam Chair, and I may have stated it poorly, but she raised the analogy before of what if somebody walks into the treasurer's office, essentially during tax time, pulls a pistol. It's not going to do that it will not give you that critical incident for non-law
Right.
enforcement. That
Okay.
comes from an EAP.
Okay.
But in terms of counseling, this will give people access to more providers with a cost share.
Got it.
Okay?
And the cost would be for what we're seeing EAP for now, those low-level people, would be $40 per visit.
Correct. So some portion of that, Verlin, we got to go in and look at Amanda's showing me copays. Just to give you an example.
30 and 50.
Okay, so the copays today for in-network mental health on an outpatient basis is $30 copay. Okay, so we can lower the copay on Teladoc relative to an office visit for medical, right? So we got to go back and say, can we do something like that here as well without running afoul of mental health parity laws in the country? That's the feathering we have to do to make sure we comply with everything. Again, a quick conversation, but not something I want to do as a hip shoot in an open meeting.
Okay.
To sum that one up, here's what I'm suggesting. If you want to do that, right, when you get to the motion part where we're talking about benefits, what I would suggest is direct staff to go back and price out recommendations and come back with recommendations to finalize implementation of Teladoc into the benefit plan starting in July.
Is that okay?
And I like that suggestion because I don't think the county as a whole is satisfied with the EAP that we have now and the providers
Agreed.
that aren't available. However, I also don't think that now's, with the current worldwide issues that we have going on, I don't know that now's the time to take that benefit away from our employees either.
I think that's going to be your conversation, Madam Chair, when you get to motions.
Okay.
Okay? All right. So, when we get there, I'll sum them all up, okay? Because I know it's a lot. The next one I think I'd like to talk about, Madam Chair, is the helicopter issue that Rick mentioned yesterday, okay? So the background on this one is the historical one, and it's what's haunting us today, is back in the Carter administration in 1976, the federal government deregulated the airlines, okay? And when they did that, an element of that was they eliminated the state's ability to regulate anything that flies, period. If it's got wings, if it's got a rotor, if it's got a motor, it's federal, okay? What they inadvertently did in there is short-circuited a long-standing area of state price regulation, which was ambulance care. So the states regulated costs and pricing for ambulances, and it included at that time primarily fixed-wing aircraft, and there it lay until about 10 years ago. So about 10 years ago, as helicopter evacuation came into play, and we see a lot of it here in rural areas, but it also happens inter-facility in cities, in metro areas, is the helicopter operators figured out no one could regulate their costs, okay? What we have seen in the last 10 to 15 years is the cost for setting a helicopter down used to be $1,200 to $1,500. It is now 10 to 20 times that, just to put the thing on the ground, okay? And then the per mile charges have done the same. So what we are seeing across Arizona is that the bottom on a normal helicopter ride is a minimum of $25,000 to $35,000 in the average, and they go up from there, okay? So what Meritane's proposing, because no one can touch them, feds can't touch them, states can't touch them, okay? What Meritane's proposing is they will attempt to negotiate with the helicopter providers. They will intervene themselves. They'll take a percentage of any savings they get from the build rate to what they negotiate, okay? The noisemaker, and that's where the county, this trust has always been sensitivity, is where do my employees get caught in the middle? That's what I want you to understand. It's where, when you consider this one, is at the end of the day, if the helicopter operator refuses to accept whatever reimbursement Meritane offers on behalf of the trust, that provider can balance bill the employee, and then Meritane will provide someone to negotiate on their behalf. The reality is the employee gets leveraged at that point. That's going to be an uncomfortable place. I think this is a good benefit, but I can tell you your employees will, to the degree somebody gets caught in the middle, your employees will be uncomfortable, the phone will ring. Okay? This is a frustration point. I'm a pilot. Many of you know that myself. I think these people are air pirates. I think they're pirates with wings because they've found a loophole and they are abusing the heck out of it, and shamelessly. I think Tony Soprano would be embarrassed by what these people do if he existed, okay? But you need to understand that if we do this, the employees who get caught in the middle where that provider refuses to accept it, they could be caught. If you would do it, and I would recommend you do it. Okay? I'm not also Ken, and I'm not you or people or Mike, where people are going to be calling me to complain. What I would say to do in the background is empower ECA to work with Ken to just pay the charge if we can't, to keep the employee out of it. But give Meritain the authority to negotiate. Let's see if we can get some savings. We're not out anything if we do. If it gets crazy and the employee's going to get caught in the middle, then we'll pull the trigger and pay the billed charges. Be happy, Madam Chair, I can see your microphone wiggling. I know you got a question.
Just, doing all the intended consequences. What ifs? How, historically, how many use helicopters?
Rick said there's only been one in the last, I think he said 3 years.
Which is interesting because in Bullhead City, that's kind of the policy, is that they fly any kind of emergency either. I mean, they'll fly them literally to Havasu. And I know how expensive it is. But yeah, so all of this for something that people can individually buy helicopter insurance.
Well, and I'll tell you, I'll give you a guess on my part, but what I'm telling my other county clients, I've got 9 of them, so I'm talking St. John's and up on the Navajo Res, I've got some out in some remote areas. I am expecting to see an uptick in helicopter flights, I'm guessing, with COVID because of the lack of respirators and ICU units in rural Arizona. I don't know if you're going to hit it, because I know we've got ICU beds up here, but I'm expecting that to the degree they get swamped, right, that they're going to have to transport either to Vegas or to Phoenix. So we may see some of these helicopter rides more than we have seen historically. I don't know. That's a guess. So I would tell you, don't feel any pressure on this at all. I see it as a good place to experiment because it's a low volume area. And if you have a fallback that says you can pay the claim, we're not going to let the employees get leveraged by a provider.
There are insurance companies I was just talking about that just do this, the air flight. Is there any way of negotiating half of the county so we can get a really good rate for our employees? That's just something that came to my head.
We've attempted that unsuccessfully in the past.
Oh, really?
Yeah, because candidly, what's their incentive? Right? When you think about the way it works, for the emergencies in particular, inter-facilities can be scheduled, but the hospitals own the landing pads.
Yeah.
So they decide who lands on their pad. So the alternative is then you have a ground transport out to the airport to load them. And we're not going to do that in an emergency because you're going to risk somebody suing, subsequently saying you interfered. So because of those hitches, we've never been able to do it, even when we've offered 100% of the business for the transport.
I wonder if there's going to be something in the federal bill that's going to take this into account. Because like you said, people are going to be flown in, maybe even ventilators flown in. I don't know, but it's concerning.
Well, there's something going on that NACO's doing, and I know that because Craig Sullivan has asked us. We have great volumes of information on this for all of our clients in rural Arizona, and Craig Sullivan has asked us for supporting documentation on the average cost of helicopter that NACO can use. So something's moving.
Okay, good.
So here's what my recommendation is at the end of the day, when you get to this, if you wish to do so, is authorize us to do the contract or to do the service with Meritain negotiating the helicopters. In the event they cannot reach an agreement and we have to pay bill, you can either authorize ECA or ECA and Ken or ECA in the chair to then pay the bill so we don't get a leverage on the employee, the middle ground.
Questions?
Okay.
Okay.
Okay. The next one is, okay, so we got the helicopter issue, we got telepsychiatry. Livongo whole person. And Missy, are you on the phone in case I mess this one up?
Yes, I am.
Okay. So this is a recommendation to expand the existing Livongo diabetes program. Okay? And what we're doing with this, or what we're recommending with this, is we're looking at the claims data, period. And what we see in your claims data is you have exactly what everybody else has. You have that combination of people that haven't gotten to diabetes yet and that have the corresponding, and I apologize for this term, comorbidities. Diabetes doesn't occur alone. It tends to occur with people taking hyperlipidemic drugs to lower their cholesterol. Oftentimes they will have high blood pressure. It's that combination. I call it informally the Gordian knot, because it's an aging population that tends to be overweight, that has cardiac issues and some degree of diabetes. Okay? So how do you untangle it? So we know from experience with Mojave that the diabetes program has been more popular, more successful enrolling people than with any of our clients. And the budget actually reflects that. Because what we typically see in the first year is we hit pretty much where we expected. We actually lowered the budgeted number in the second year by about 30% because it tends to level. So it'll actually drop and you'll maintain a certain number of population. And what we saw instead is we had to budget in an additional 10,000 because people were not only enrolling, but they were staying and more people were enrolling. So that was good. So they clearly like it. The whole person goes after those other comorbidities, and if you'll remember from Missy's slide yesterday, what we're really looking at is people who have 2 or more. So it's a very small population of people that are 100% target rich, okay? And we're recommending that you do that as a way to kind of get ahead of those claims, period. So the actual additional cost, if I remember in the budget, is an additional cost of $78,000. Missy, is that right?
That's correct.
Okay, if you decide to go that way. The irony, and this one's actually kind of funny, and Mike was talking about selling yesterday. Frankly, at the end of the day, we don't have a dog in the fight. We're not selling their product. We bought them in because we see in there the type of combination of claims that's costing money on the trust. And we know that things like the diabetes program has been successful. We know that on the mammography screenings it's been successful. We know that because we've seen the breast cancers and the things that have been caught. So this is an area that we believe may benefit the trust over a couple of years because it's targeting that specific area. But at the end of the day, you guys have to make that kind of a recommendation and a decision in the environment you're in. So we're recommending that one at an additional cost of $78,000 into the budget.
Yes, Madam Chairman, you're requesting an additional $78,000 in the budget. What do we get for $78,000?
And that, if you remember the program yesterday, and Missy, you can jump in on this. This is the one where the people who meet those criteria enroll. I
saw that one.
So
but what do we get specifically for the $78,000? Is it the program? Is it what?
It's their services to manage the people that meet that population, Susie. So the people who, and Missy, you can jump in, but who meet the criteria for high blood pressure, hyperlipidemics, weight, who are pre-diabetic. So now we cover the spectrum all the way up through diabetes. And so you're paying
I also saw some stuff that is this going to purchase things for employees? I saw the picture, and there are some things that they need to be part of this program. Is it $78,000 purchasing that, or it's just to establish the program?
It pays
and the
for
cost
all of
those equipment are still borne by the employees.
It pays for all of it. And so it pays for that. It purchases that. The blood pressure monitor, it pays if they're qualified for it. It pays for the scale. It pays for the coaching services. What else, Missy?
But that's the cost of the employee, not the $78,000.
Zero cost to the employee.
Oh, zero cost?
100% paid for by the plan.
Okay, so the $78,000 would cover those.
Covers everything.
For the employee.
100%.
Madam Chair, follow-on question on that. So I was looking at that picture yesterday too, and was kind of curious about that because it looked like there's a smartphone there, as well as some type of an iPad or something like that. That was all part of that picture and what a person would have to have. But I was also curious. You said it was just targeting certain individuals that have those prerequisites of blood pressure, pre-diabetes. So they're not going to be going after someone that physically needs physical fitness, or it doesn't, somebody that weight control or something like that. Are they pushing it out to everybody or just that select group?
You make it available to everybody, but the only ones who can enroll are the ones who have the condition and meet the criteria. So in other words, they have to be on a blood pressure medication, that we have to know they have high blood pressure. They have to have a prescription and be treating for diabetes, or they have to have a BMI above a certain level. So you're treating 100% of the population has the condition. The alternative to that, the contrast to that, Roger, is that when we do mass screenings like skin cancer screenings or breast cancer screenings or prostate screenings, we're screening an entire population to find them. In this particular program, they have it to get in. So you're treating 100% of the population with the condition you're trying to target versus searching for it amongst the broader population. That makes sense? Kind of reversing it. So you've got your population, 100% has the condition. Okay. Missy, did I miss anything in there?
Nope, you covered it.
Okay.
Okay, any other questions?
Madam Chairman?
Yes.
Since I'm new again, do we have a cost to the diabetes program that we currently have right now?
Missy?
I'm sorry, that's what was budgeted currently, and I believe we're at $54,000. Is that correct?
I'm looking.
Amanda's checking.
So we currently have a budget for that program right now. Is this 78 be on top and above that budget, or it will take over the budget for part of the budget for the diabetes program?
So as of now, the cost is approximately $50,000. That's what we have budgeted for the program that's in place now.
How much is it? I'm sorry.
For the diabetes program now, we have budgeted $50,000 based on the population that's enrolled now. So this new program, this additional product, would be an additional $78,000 to that $50,000.
So we have a diabetes program worth $54,000 or $50,000. Then there's being recommended another program platform which would cost the trust $78,000 above and beyond.
Correct.
Okay.
You're confused.
Is that good? I'm sorry?
You're confused, I can tell, so I want to make sure you understand.
Well, we have a basic diabetes program right now, and I understand that we're expanding it for this platform, but I don't understand how we can fund both.
Okay, so it's not redundant, Susie, and that's what I think the confusion is.
Okay.
So today the program only does diabetes, so now it's expanding it back for high blood pressure, cardiac conditions, and for pre-diabetes, which does get into issues like weight and BMI. So what you're these are people that are further down the scale that do not yet have diabetes, but that have other conditions in addition to it. And this is moving down the scale to cover those as well.
Okay.
Okay?
And those people would have to sign up for it.
They would have to, they have to go through screening to enroll to make sure they in fact have the conditions that the program is targeting.
And I enroll in it. I'm sorry if this was said yesterday. I enroll in it, and what happens? What do I get?
So you get, and Misty, you got to help me on the specifics, but depending on the condition you've got, you're going to get a blood pressure cuff if you're on on blood pressure medication to make sure you are in fact testing. It uploads not through your smartphone, but they're all cellularly enabled independently, so you don't even have to have a smartphone. So you're taking your readings, it's monitoring what your readings are by day. When you step on the scale, it's monitoring your weight, and you get an individualized coach specific to the disease state to help you make the changes you need to lower your risk. And for you as trustees, the risk is what ultimately translates into claim dollars.
I really wonder if that's something people would sign up for.
Madam Chairman?
Yeah.
It does, on page 58, it talks about that there would be shy of 500 people that would be eligible for the pre-diabetes. There would be 157 that would be eligible for the cardiovascular solution. Of those 478, 10% is projected to enroll. That's just a projection, so it only apply to less than 50 of our employees. On the cardiovascular, it says 20% would, is projected to enroll, so that would only be like 30 people, just to answer your question.
Right, 30 people, maybe.
For $78,000.
And how would
Cost
they
would be
know? I
100.
mean, we would send out something, and if you're unhealthy,
Yeah, if you've got these types of, if you're in this situation, you're taking a blood pressure medication, you've got a BMI above, if you've got this type of thing,
Right.
we have a program, it involves these things, call this number,
Yeah.
go through the process to see if you're eligible. If they are eligible, then, and they wish to enroll, then they go through the process to get the member packet, to get set up, to get the devices, and then to get.
it's almost like
in the system
wellness
for-
in a way. When you have diabetes, you have diabetes. When you're, this is, can be considered preventative. Anyway, yes.
Madam Chair. With our $50,000 though, and those people who signed up for the Livingo before, you can quantify how much savings to some degree, can't you, for that 50,000? And would we be able to project possible savings for the next 30 or 50 that signed up for this $78,000 program as well? I'm assuming that all the people that, Mike just talked about would get some kind of a flyer saying you're eligible based upon a medication that you take. So then if they were screened, or even a percentage of them was screened, would we be able to know approximately how much, based upon this program, that the county would save in medications or treatments?
Yeah, and Berlin, you're getting exactly to Mike's issue yesterday, which is everybody has an ROI figure, it's return on investment that they do, and Mike spoke like an engineer and did it really eloquently yesterday. He could basically show me the money, okay? And it all comes down to the methodology, okay? So let me give you how that works, because you're trying to prove a negative. And I agree with you. This has been a challenge for us as a firm over the years. How do you measure what didn't happen? So with chronic disease states, like diabetes, like hypercholesteremia, basically get the stuff that clogs arteries, they have normative data and population data. This group is too small, period. It's just not statistically valid. What they can tell you is, based on the presence and the severity of specific risk factors that are measurable, that those individually and in combination are an indicator of what your claims will be. With diabetics, A1C is a huge one, right? With the general population who's at risk, and Missy's probably cringing right now because I'm doing this and it scares her because I'm a numbers guy doing it, but on men, for example, waist circumference is a big one. Waist above 40 inches puts you at risk for certain things. So what they will tell you is, to the degree you control those risk factors and improve them, you reduce the claims dollars that will ultimately come out of your fund. Now, I'll give you the alternative on that I've seen actually play out, and with diabetes, where you get the ones that blow the curve on small groups. We have seen in multiple times through 2 different vendors we have used for diabetes, where the diabetic only enrolls in the program after they go into kidney failure, or after they are at risk or actually lose extremities, feet typically. Okay, so when they go in, they come in, they've already crossed the critical thing. It's just all of a sudden they realize too late the problems they've had. The intent of these programs is to catch people further down, give them the option, really, because they don't have to enroll, but give them the option they have when they're back here before they've progressed to actually the disease states causing them grief, and to give them the tools, if they choose to take them and to follow them, to manage the disease state to avoid the progression of the condition. And again, I just want to stress again, what I'm doing is giving you information. This is the basis, our thought process behind the scenes. You're going to do what you're going to do. I don't want you to feel like you're being pushed.
No, and one more thing. I mean, we look at the numbers on who utilizes our preventive, like the POPs, which we talked about. It's a very, very low number. And I don't mean this disrespectfully or anything to anyone, but, people who don't take great care of themselves I don't think are going to pop up and say, today's the day I can call in my blood pressure. So, I just have some problems with it. That's all.
Missy, do you want to add anything that I forgot?
No, you covered it. Thank you.
That's high accolade for the record.
I think we've whipped this one. Okay.
So, and then the one that I know that had everybody confused yesterday because it is confusing. The last one is copay max. So, and we talked about this one last night at dinner because it's a hard one to do. How do we get this one across? Let me try one more time. Okay. And I'll use myself. I'm going to use myself as an example, and I'm reaching all my HP. I'm a cardiac patient. I've had multiple cardiac procedures, so I'm on a drug called Repatha. And Repatha is a specialty medication for people who are at risk for a cardiac event, and it's a cholesterol lowering drug. It's a tube that I get. It looks like a cigar case, and on the 1st and the 15th every month, I pop it in my leg, and it does magic stuff, but it's a specialty drug. It's one of the ones that's covered by this program. So Repatha, because it's expensive, has a coupon. You call a number, and Repatha gives you $500 towards your out-of-pocket max. So it covers most of the cost of the script for me every month when I call it in, right? And so what's happening today, okay, is that those Repatha coupons are showing on the plan, this plan, as having been paid by the member when they have not. Okay, so that $500 gets credit towards deductible or out-of-pocket max, and the member's not paying it. The plan was intended that the members would pay those dollars, but this is a way the manufacturers have gotten around it, and believe me, no one's going to complain. Okay, so what this program does with Navitus is at the point the member presents through the specialty pharmacy the prescription for a specialty med. Navitus intervenes, pulls down the script, applies it, waives the members what they would have paid. Mine is like 15, 18, 20 bucks. So I get it free, right? But the value of the script does not apply towards the out-of-pocket max. I still have to pay the costs I otherwise should have paid. That's the noisemaker.
So basically, it's been a loophole for a long time.
Correct.
And now we're just righting that.
You're closing. It's exactly what you're doing.
Unintentional wrong.
Yeah, there's never an intent on the plan to do it.
Exactly.
Right? Employees always knew they had to pay it. It's a good deal, but I guarantee you for the 10 people who are benefiting from it, they're not going to be happy.
And it'll be at $40,000 to the good for us, did you say? What was the dollar amount?
Based on the current rates, Mike, it's a $40,000 savings to the plan.
Good memory.
Couldn't say that yesterday.
We did, I know. You guys were tired yesterday. We were tired. Everybody was cranky, you know. All right, so Madam Chair, believe it or not, that's everything. So I'm going to have Amanda go up and pull the budget up. So here's
Madam Chairman, can we take a little break?
Yeah, let's take a 10-minute break. 10, let's say 10. So
Okay.
it is 10:53, around 11:05, okay? All right. And there is some munchies in the break room here, the conference room, if you're interested. Donated by Erin Collins. Thank you.
Welcome. Everybody's got to eat.
Holy moly.
news I was watching, they happened to make him get up or something, and he had a suit on. He had these looking little skinny high top tennis shoes, and it was like, you stay behind the thing.
His wife didn't let him go out like that?
Mm-hmm. And once we finish this meeting, we'll just 5 minutes for her to switch some stuff over. Byron will call in. He'll give his update when we're done. Okay. We have him on kind of standby to call in. Yeah, so he'll know as soon as we end, he'll call in, and then we'll the live stream off. No, actually. However, they are supposed to follow the less than ways. Put together all these meals for these kids so that any child what's yeah, it was actually a pretty
They do that in Bullhead schools. They're doing that because they got some money.
yeah.
Getting paid for it.
But you know, it's kind of good because a lot of those kids meals otherwise. So I was glad to see that. So that's a big.
Okay.
Are we back in session, Madam Chair? Two's the same. 2 and 8 are essentially the same.
Oh, okay.
So are we back in session?
Excuse me. Yeah, well, we got to get everybody here.
Oh, okay. All right.
Everyone, well, Mike.
Roger.
Roger.
Sorry.
Okay, I'm going to reconvene this meeting, and we are now on, excuse me? Yeah, it's on. I know, I'm talking so quietly. Okay, so now we'll go to 8. Discussion, consideration of, and possible action regarding 2020 to 2021 MCEBD budget, benefit changes, and rates.
Okay, so Madam Chair, I'm going to ask Amanda to pull up the budget. And let me start out with big picture and then come back with a suggestion. So in essence, what the actuary said is that we can technically cut rates. You never cut a rate, right? So you basically hold them flat. So what we did is, in the budget that Amanda has, we incorporated all of the fixed cost charges that we did. So the assumption of the 25% increase in the stop-loss premium, we incorporated basically all the fee increases for the vendors. And then we assumed, and this is just to give you a starting point for your conversation, we assumed you would approve the... we can't
see very well on our monitors, but on this.
Okay.
Made it bigger now. Before we...
This is really clear.
Let me know if this is okay, because I know what you meant, but I can see.
Better, thank you.
Okay. Thanks, Mike. So we made some assumptions to give you a starting point. And we assumed that you would not cut any funding, but that you would hold the current funding factors flat. We built in the cost to add the preventative dental to the low plan. We left the costs in for the employee assistance program, so we left that $144 in. We built in the cost of the Livongo whole person. We built in the savings for the life and short-term disability. We made no provision for the helicopters or for the copay max provision program. And we assumed that so that you would then, for any of that, by the time you all got said and done, if we didn't change the funding factors, what would be the change to the rates? And the change would be, I'm sorry, the change to the budget would be roughly 0.5%.
I don't know where you're going. I didn't know where Aaron was going. He was saying rates, so I started to go back up.
So I apologize. So the cumulative effect on the budget would be less than, right at 0.5%. Here's what you have, you can make changes to any of that. And I haven't done your part in there yet. So there's no provision there for the psychiatry. I'll come back to that. So in essence, when we did that, you could make every recommended change and hold the rates totally flat. And if you drop any or add any, our suggestion is going to be do that and still hold the rates flat, because what we want to do is preserve as much of the funding factors as we can, just for the general budget, and also to deal with anything that we have coming up on the COVID situation. In terms of Verlin's question on adding telepsychiatry, okay, what we would need to do is to go back, get with Chris, the actuary, figure out what benefit structure we could feather in to make it consistent with the existing benefit structure in light of federal law on non-discrimination for psych and substance abuse, and then find out from him what the costs are and whether we can also absorb those into the rate. So that's what we would have to do on that one. So from your perspective, to put a handle on that, there is no cost impact regardless in our projections, because we didn't project any cost increase on the helicopters or the copay max, even though they are expected to have some savings. We just had no way to do it. And then each of the other benefits has some cost that's included in here. So my suggestion, Madam Chair, would be ignore the budget for the time being, because we don't think it's going to have a rate change. But why don't you go through item by item and decide which of the programs you do or do not wish to do, and then we can take it from there. So if I could suggest, Madam Chair, I'd say start with the dental. I think that's the easiest one with the least discussion. Okay. The question is, do you want to add 100% of preventative care? No restorative, no anything else, just preventative care, so the cleanings and whatnot.
Okay, we need that in form of a motion?
I think that would be a good way to go.
Okay. Okay.
I move that we add the 100% care coverage.
Thank you, Artie. Okay, all in favor?
Aye.
Aye.
Opposed? Motion carries.
Can you give us tallies, Madam Chairman? Can he give us tallies as we go?
Yeah.
Okay. Let me see. Okay, so we got the dental done. On the EAP program, so our proposal here is to non-renew Holman Group, the EAP, it's EAP, case management, and the House Bill 2350 vendor as of July 1st, to leave the budget in place as it is at $1.44 PEPM, to incorporate the cost the Sheriff's Office has for their 2350, House Bill 2350, and the other, anybody covered under 2350, to cover their PTSD out of that item, and also to cover the Sheriff's Office costs for the annual testing for the people who are in the sex crimes unit. The annual evaluation for the people in the sex crimes unit, and then to direct staff to ECA to work with HR staff to conduct an RFP to potentially replace the EAP for the 21-22 year. That's the staff recommendation.
Okay.
Madam Chairman?
Yes.
Just for clarification, we're holding the budget for this coming fiscal year for EAP, but we can revisit the issue in the next fiscal year.
Correct.
But Mike asked if we can have a running total. Are we going to do that?
Yeah, what we'll do is we'll know, that way we're going to use the time with the Sheriff's Office expenses to actually get a handle on what the costs are going to turn out to be.
Is that what you meant?
No, I wanted to know how much we added for the dental, a running total on how much increase.
Oh, I got it.
And Madam Chairman, I thought, and I would support, I believe, where Verlin was going. If we're going to include it just for the sheriff's office, the price that we obtain should be for all PTSD, and we probably need to include the mental health yearly exams for those attorneys that are in taking the sexually violent and other cases like that.
Mike, and Madam Chair, I'm great with that. What I don't know, Mike, and the reason you see me doing this is I know the Sheriff's Office has an adopted protocol. I'm not sure if the Attorney's Office does, but I would say if they do, and then we have the money in the budget. The Sheriff's Office has a real specific adopted thing, so I'm assuming do you want them to joint purchase or collaborate and use that same thing for like the prosecuting staff?
I'm at a disadvantage to a certain extent because this hasn't been discussed with the Attorney's Office and with Matt Smith or with, I haven't gotten any feedback from my Indigent Defense Services attorneys on this. So this is all new, but I would assume if the Sheriff's Office is having this need and they've got people that are placed in these situations that could conceivably have them get PTSD, that other areas that do almost the same or similar jobs should be covered under this program. That's what I would think.
Madam Chair, can I ask a question? If we're taking out the EAP program and holding that money, but then we're using it for the sheriff for this other thing, we're really not holding that money. So a year from now, when we want to spend that money, what's the sheriff going to use? Aren't we using that same money?
That's a great question. What we expect to have happen, Madam Chair, in Berlin, is that we will whatever the Sheriff's Office spend will give us a solid number, and then we're going to come back with the RFP for a replacement provider so that we will then budget them as separate line items. So we'll break it out and acknowledge, here's what the Sheriff's Office thing is costing, here's what the EAP is, because I think there's overlap with them, and we may be able to handle parts of them with each other. So that it's basically a place marker. We're leaving the line item in, we'll spend the money that we have for the Sheriff's Office, and as Mike said, if the county wants to expand it to these other ones, the pool of money will be available, and then the EAP will come back in and break out the expenses based on what happens with the RFP process. So it's part of this is by guess and by gosh. We really don't know what the costs are going to be for either what the sheriff's currently doing or with the additional expansion that Mike's contemplating. So it's given us a place to put it into the budget and then record the costs as they come.
Madam Chairman, I think the question that Verlin raised is legitimate, which is, I think if I understand what you're saying, is that, okay, for next year, we're going to use the money of EAP, the program is still going to be there, but it will not be funded for next year. But then the year after that, once we have used the money for the sheriff's office, there's no money for EAP for this second fiscal year we're talking about.
Correct. So basically, we're adding a new expense to our budget, the sheriff's two different line items. We're adding that to our budget this year and taking away EAP.
Correct.
That next year we want to incorporate again.
And that's what I was saying. I may have said it badly, Verlin and Madam Chair and Susie. What I'm assuming is we're going to do an RFP for that second part. So we're going to use an existing line item for the sheriff's office and whoever else, right? Just because the money's there, we don't have to change the budget. We'll then do an RFP for an additional program, and we will propose that just as we have here with other ones, with costs associated with it for the 21-22 year.
So what happens then to the sheriff's program?
My assumption is you'd keep them both. You just have to fund them both. And you may not. In Berlin, I see it, but you may not. But that's what we're proposing. And again, for the record, guys, you don't have to. You can say, we're recommending it. You can say, pay for it somewhere else and eliminate the line item and then credit it back. So we're thinking this is a way to kind of get it where we cover the spectrum of what I think county staff is saying they want to accomplish. So that's just our way of doing it. It's a little bit of baling wire and bubble gum, but it gets us to the point where we can hopefully have a replacement program that's more responsive than what's happening now. I think the frustration with the current vendor is that it's been put out there to people saying, call this and we'll get you some access to care, and it's not working. So we're trying to figure out how do we best do that.
All right. Everybody understand? I say everyone like. Okay.
You want me to restate so you have the option to do a motion?
Yeah.
Okay, so the staff recommendation is to leave the dollar amounts budgeted for EAP in the budget at $1.44 PEPM, to non-renew the current vendor for the 2021 year, to use the existing budget to offset the sheriff's office and any other county programs that have PTSD-like circumstances for those charges, and to also pay the sheriff's office once a year assessment for the people in the sex crimes unit out of that budget. And finally, to direct the HR director and ECA to collaborate on an RFP for a replacement EAP vendor for the 21-22 year.
Okay. I need that.
Madam Chair. In the alternative, can we make a different motion that does all that except leaves the sheriff's out, but gives you, or that portion out, but gives you the ability to work with the HR director to come back and tell us what we could get with Teledoc or some other program to put in this year?
You could, and I'm also expecting that to be a last action item. Separately, you can do it as a replacement for Lynn. You can do any motion you want, but I'm expecting that when we get to that last item on Teledoc, that we'll get somewhat separate direction. If you would like, maybe a suggestion would be to table this item, and let's do the Teledoc one so we can get direction on that, so we're clear that that's not being left behind.
Madam Chairman, I would somewhat agree with that comment. I couldn't vote toward the motion to approve this. Essentially, if I understand all of the discussion, what we're doing is we're leaving the rate ingredient in the in our budget to collect as far as or pay or have ability to pay, but yet we're deferring everyone's benefits strictly to a certain group. To essentially everyone is paying if there's any participatory fee, on the employee side. Now, there may not be, maybe I don't understand, but I'd like to see this tabled also, and possibly see what an RFP would bring or Teledoc would bring. Thank you.
What say you on that? On what his comment was?
Oh, I'm sorry. Say it again, Madam Chair.
What is your response to that?
I think I know where Verlin's going, and I think the only thing you're seeing here is some confusion. I'm trying to make sure we hit what everybody's looking for. What I would suggest, Madam Chair, just let's leave this item and for the moment and come back to it. Let's address Verlin's issue on the site, because I don't think there's a lot of overlap between these. And again, I stress our issue today with the EAP is we have a vendor that's not performing. Period. That's separate. Okay, that's not making a judgment on the need for the services. I just think we have a non-performance issue we're trying to fix, and we're doing some other stuff kind of in the meantime. But if we go back, Madam Chair, if we could, on the telemedicine, what I would suggest the board do is, and with the recognition that you're not going to be able to adopt final rates today, okay, is direct ECA to work with the vendor on implementing Teledoc's telemedicine proposal, and to come back with recommendations for how to implement it in the high deductible health plan and the EPO in conformance with federal law, and to make recommendations on funding for it.
Okay.
Moving on to the A's and the Living-Go and all that.
No, this one I'm suggesting that you actually do. You give me that direction in the form of a motion because under the assumption your intent is to add the psych benefit under Teledoc, that you direct me to do that. I just can't do it today because I have to get those things done. So what it'll mean is that you'll do the rest of these, you'll do that one, and then we'll come back with the final rate picture. We'll schedule a real quick meeting in the next 10 days. Probably telephonic, and give you the final recommendations.
Okay.
So, Madam Chairman?
Yes.
I would make that motion to go ahead and include the psych under the Teledoc.
That motion also include eliminating our existing.
And eliminating the existing EAP.
Okay. Artie, anything? Yeah.
No, I still can't endorse that, but no, I have no further comment.
And including it under the teledoc.
Or is it just for this?
Let me clarify what I think's happening, okay? Because I think the intent here, and it might be combining the two, Mike, so let me know if I screw up what your thought process is, okay? So I think the intent here is to put in teledoc, to eliminate the EAP on 7-1 as it currently exists, and to implement the psych benefit on teledoc. We will still have to come back with the exact benefit design, because it goes differently into the two plans for legal reasons, and we'll have to come back with funding. But your intent is to implement teledoc for psych 7-1 with those caveats, and then eliminate the EAP. That leaves open the issue of the funding in the sheriff's office, which we'll handle in a separate item. Is that your intent?
Sorry, I didn't know how it's funded is going to be, unless the board, this trust decides differently, is through the funding process. It's all general fund money anyway.
Okay, because currently, Mike, we have that $1.44 in there. For the
you mean who funds the employee portion?
No, on the EAP, did you want, in other words, what I'm trying to get at is, do we keep the $1.40, when you say get rid of the EAP, which we're recommending as well, does that mean you want to eliminate the $1.44 funding that we have in there currently, because we were going to use that to absorb the sheriff's office costs?
Madam Chairman, I see it's all the same thing. You know, you eliminate it and establish new funding, or you keep this in place, and I think that would be confusing. You're going to come back. What I understood was we're going to have teledoc with several levels of employee assistance, you know, depending on what the employee would like to have, and you're going to come back and tell us what the funding is. What you also told us is that the EAP program, currently, we don't have a provider that's performing. So, and I understood that you could switch the responsibility and through teledoc provide a like service as was intended to be provided through EAP. So teledoc would replace EAP in our program, and that's what's going to be offered to our employees. And you're going to tell us how much that's going to cost. And the reason that it's not a great concern of mine is because our fund is doing so well that unless it's an exorbitant, we will be able to afford it. And you know, I don't believe there's going to be a tremendous difference unless you can tell me differently.
Yeah, well, I don't think there's going to be a tremendous funding difference either, Mike, but the telemedicine psychiatry will not replace the services the EAP provides. It will, because the EAP provides additional services that are specifically addressed in some of the concerns Verlyn voiced, but services that are not done in the telepsych. They're actually lower level than psych. And that's the two. They're getting kind of mixed in there, and I apologize. I get that it's confusing. Let me, at the risk of getting more confusion, let me offer a third alternative, which is vote on the telepsych, tell us to go back and recrunch the numbers. In the meantime, we'll get with Ken and with Mike and figure out what the recommendation is on the EAP and the sheriff's office stuff, and we'll include all of that in one item when we come back.
And Madam Chairman, my intent, and I apologize for misunderstanding, but my intent is to protect the county in regards to what may be legislated in the future, and also to provide and not lessen our employees' ability to utilize, the type of service that EAP provides.
It's all confusing now.
It's very confusing. But they can, but our employees can get mental health through our regular. This isn't the only mechanism for mental health.
There is a mental health availability provider issue that this teledoc thing fixes to some degree, because you still have a lack of providers that are taking, even in the Blue Cross network.
Right.
It's just the nature of the beast.
Right.
There's
I'm just
always.
trying to. Mike was saying that there's this in between time, right? Is that what you were just saying? Me able to do it, but I'm saying if they need, they're still, because we don't have a teledoc contract yet. So we're talking about that period between when you come back and now.
We have a teledoc contract for medical services.
Right.
It does not include the psych today.
Right.
So we're going to expand it.
Okay.
So if someone needs something tomorrow, they can they'll be able to go to a doctor. I know there's not a lot, but there are some.
Correct.
Right. I mean, nothing we can do today is going to give them for tomorrow.
Everything you're doing now is for July 1.
Right.
And it will not, I believe it will actually expand the availability of providers because now just instead of Arizona, Teladoc has national providers in these specialties. So I believe we will actually get for psych, for a range of psych services, we'll get greater access through the Teladoc proposal. It will not fully address all the EAP issues. It will not address the issues of the sheriff's office.
Right. Of all the things Teladoc can do, I think this kind of service is the best because it's talking.
Madam Chairman?
Yeah.
To make it less confusing for me and for everyone, let's not try to switch funding. Let's deal with Verlin's issue, add the additional psychological thing in the Teladoc. That's one issue. Get a cost for that, and we'll talk about it. Leave EAP alone as a funding. And then at that point, you can decide, okay, if we're not using it for 1 year, maybe for 1 year we can use it for whatever Mike was talking about in terms of, the sheriff's office. But to mingle all three together, it's more confusing. If Teladoc budget is going to increase because of Verlin's recommendation, let's just talk about that and say, okay, can the trust accommodate that increase in the Teladoc contract? Just leave it there.
That works.
Worse?
That works. You're good. You're on a roll. Keep going, Susie. You're on a roll.
Yeah, so that's one issue. We solve that. Then we have the EAP. EAP, we have a problem right now. We want to retain the funding. Leave it there. Then you can talk about Mike's issue of wanting to use some of that for the other services for the sheriffs and the rest. But to commingle all three, it's more confusing.
Madam Chair. And I believe I seconded the motion.
I can withdraw my motion. I'd withdraw my motion.
You need to withdraw your
So, and I withdraw the second. So at this point, can we make a motion to not go with the EAP vendor that we've been using, but to use that $1.44 in holding until you come back with a different possible solution for the upcoming year? If that's okay, I'd like to make that motion just to get that part of it out of the way.
And I would second that motion.
Okay.
Okay.
Madam Chair,
That works.
Yeah.
got a question. Well, but I thought that possibly part of that motion could be that those funds could be utilized for the sheriff's department. Weren't we saying that?
I think
with the EAP for next year, holding that.
Madam Chair, Roger, I think where Verlin's going is she's breaking it out like Susie did. So this is the first motion that says put in Teladoc in July 1 and leave the EAP funding as it is. And I think she's doing that, and then I'm expecting there's going to be some follow-on motions here.
Yeah.
Right. So I think that's a good item. I can tell you we can live with that item with the budget, assembling a budget. We can live with that motion very, very easily, and then we'll find out where these other motions go for the EAP, for the sheriff's office and for whatever else is going to follow into the EAP. Is that where you're going, Verlin?
That's my motion. It has nothing to do with the sheriff and that funding. It is only to leave our existing funding in place until you give us a possible solution on a different vendor, whether it's Teladoc or somebody else that could meet our needs for our existing, what should have been our existing program that's failing us.
For July 1st. You're talking about for July
Correct.
1st. Okay. We can do that.
Okay, so we have the motion and the second. Okay? Any more discussion? All in favor?
Aye.
Opposed?
Aye.
Motion carries. Right. What's next?
That left in limbo the question of the sheriff's office funding.
Yes.
So motion would be to use that.
One way or another, I think we need to dispose of that item just so we know what we're doing and
Okay.
putting the budget together.
What was your idea, Berlin?
Well, my idea is not to use the funds that are there for the entire county at this point for the sheriff's department until we figure out what, if anything, we can do to cover the whole county to replace the EAP program. So I won't be making the motion to
Do anything.
use those funds for just to take care of the county, or excuse me, the sheriff's EAP or HB 2502 or whatever they are at this point.
Madam Chairman?
Yes.
Is that something, Mike and Coral, can you do that in a separate county budget for the general fund, rather than using the trust funds for that? For the sheriff thing?
Certainly we can do it. Certainly we can do anything. And we can go out for a separate purchase. We don't have any expertise to procure that type of a service. They do. But they don't work for the county, they work for the trust. So I don't personally see why we would separate employee services from the trust, employee insurance services from the trust, and have an individual department procure their own. I don't see it.
Madam Chair?
Well, with that in mind, then make it as a separate action for the trust to discuss as part of a trust budget.
That's what we're doing.
And is that in the trust now, somewhere that I'm not aware of? I mean, is there something in here now that addresses the sheriff and the House bill and that funding? Is that in the trust now, or is that part of the EAP program that we already have in place?
And Aaron's going to have to answer that, Madam Chairman. Berlin, this discussion was prompted by that by that bill, and in response to it. So I don't believe there was, a specific item that was addressing the sheriff's needs as it pertains to PTSD that's existing currently. Is that correct?
You're correct, Mike.
Okay, this was to expand or to target their services specifically, but maybe I kind of understand that the trust, this trust, wants to keep in place, and I agree, the funding for a program that no longer works and try to replace it with another program, another provider that will actually be able to provide the service. What that looks like is up to us. And so my question would be, I thought the solution was teledoc, and Aaron just told us it isn't. So what I would say is that we're going to go out for an employee program, and if we want to add language in it that will cover PTSD for whoever believes they have it or whoever actually has it, then Aaron could procure that service and provide us with a cost for that, and also the screening, and that would take care of both our employees' issues and cover the sheriff and whoever else may contract that.
And we can vote on that in a special meeting.
Is that true, Aaron?
That's the contract for the sheriff's office contracts. I understand are in place today. So
what
for the once a year evaluation of the people in the sex crimes unit and for PTSD.
Are they?
Okay. Apologies. Are you talking about the sex crime part or the PTSD part?
We have a contract with the provider in Prescott that the funding is there, and then they're going to start sending their people, or they were planning on starting to send their people this year based on their activity. So they haven't sent anybody yet that we're aware of, but they were in the process of getting that set up. They already do the PTSD after critical incidents. They have to do that anyway. Right, and the same provider, like says, the provider, the reason they went with that provider, and the reason we couldn't use it during our EAP is they are post-certified. None of our EAP providers were post-certified to handle the situations in the sheriff's department. That's why we had to contract, or they found a contract outside of the EAP program.
So, Madam Chairman, it seems like I just know enough information to look silly, and that happens a lot. But whatever it is, Aaron would work with HR and myself to define a plan that takes care of all the gaps that aren't being filled today. And if the gap of the assessments are currently being done, well, the plan's not going to include that because it's being done outside of what we're looking at. But you would develop a plan to address the needs of the county and procure that service from a provider. And that's what would be presented back here, whatever that may be. Obviously I can't tell you what's needed today, but I'm sure we can figure it out.
So, Madam Chairman, so Michael, is what you're saying that perhaps this board needs to consider absorbing that contract amount that's currently existing? Madam
Chairman, Berlin, if it's existing and it looks like it will function for the needs of the sheriff's office, I would leave it in place. I didn't realize that they were doing that.
But although still general fund, that's in a different budget. That's in the sheriff's own budget?
It should. Probably you're going to have to address where that's located. Is it in HR or the sheriff's budget?
Okay. Can I ask a question really fast? But this is something that everybody pays into, but only a certain sector gets to use. So if we don't do what we say we're going to do, is getting another one, we're basically taking away a benefit, but they're still paying for it.
I just wouldn't characterize it that way, Madam Chair. I get it. Here's my thing. Let's just forget the sheriff's officers and sweat the EAP. The vendor's not performing. People can't get to a counselor in the time they need to. Period. So we got a vendor issue. Okay, we were just using the line item because we know that having a vendor issue doesn't mean the service isn't needed. Right? So we were just saying, let's since we've got this other issue, admittedly, we were all conflating them, kind of mixing them, trying to solve a couple of problems in a line item while we paused to replace the EAP vendor. That's all the initial intent was when we came in. Berlin made a very good suggestion we hadn't considered, which was separate, but it was another good one. But they're all separate issues that have just become conflated for budget purposes. Mm-hmm. So if I was going to make a recommendation, I go back. I think Verlin's on a good track. Let's go back and price that, because I think that will help with the psych availability generically. Yes, it's in the network, but it's not accessible. Yes, we have an EAP, but they're not accessible. I think this is a good option. Doesn't replace the EAP. Does not address that issue. Okay, let's do it. Let's price it. Let's see where that comes out. Okay. Either way, I would tell you flat out, we should not have this EAP vendor. Okay, as of July 1st, because it's not working. Right. I do not want to get with Ken and Jade and Mike and jam another EAP provider in there, because I think we'll wind up back in a bad place. I think I would like to use this year to really look at what we can do that will work better for those lower level EAP services that none of the current structures provide for, period. Right. I'd like to use that time to really do it, okay? And I know that seems like a long time, but you guys benefited from a similar conversation with our other counties about life insurance, and we did a whole ton of work with them that did in fact take a plan year to get done, and you guys got the benefit of it today. And I'm only saying that because I'd like the opportunity to get creative on the EAP side and see if we can address this stuff. So what you're seeing today is a Band-Aid. Let's tell us to go do the thing with Teladoc. Let's get that done. And then just direct us to go back with Mike and Ken. And let's see what we can do. We'll leave that $144 there and make no decision other than to terminate the EAP vendor as of July 1. And then we'll see what we can do short term to address the issues of the for all county employees that may subject to a PTSD type circumstance, and we'll come back with that recommendation in probably in about 10 days to 2 weeks.
Agree.
Artie, you there?
Thought I heard someone echo my name.
I know, I didn't have my mic on for a change. Did you have anything to add?
No. I mean, now we're just arguing about time and, restoring a service. So.
Okay. All right, so I need a motion. We made for that first thing.
I think Verlin's motion covers essentially.
It did, and we don't have to, we've directed you. We don't have to make a motion on that. Okay. All righty then.
Coral.
Oh,
May
Coral.
I make a little bit of a clarification just on my side, perhaps. What is the cost for the EAP program right now? I know it's $1.44, but is it $21,548 for the whole year? And then the estimate that Jade has right now, then for the sheriff's portion would be $4,000. So with the concern that we're spending $21,000 for this, and then we would move it instead into the sheriff's office, we would be talking about a $4,000 use of the $21,000. That makes sense? Okay.
And then we also have budgeted in there the case management for the mental health substance abuse carve-out plan, which will also go away with the EAP because that's part of the Holman Group. That's an additional $5,000. So that's a line item as well that will not be utilized with removing Holman. So there's a total of about $26,000. Holman Group?
No. Hayes. Or it was
Case management.
The case management.
Case management.
Mm-hmm.
Madam Chair, so with us going away from this EAP program, does that affect what the sheriff's able to do with their vendor? Are they two separate contracts?
Separate items, totally separate items.
Thank you.
So here, just to be clear, Madam Chair, I think you have a motion and a second on the floor to direct staff to go back and do the pricing on adding the telepsych through teledoc and to leave the funding in place for the EAP line item. I believe that's what the motion was. That's all it covered. Is that right?
Are we going to vote?
We have a motion. We have reread. Oh, that was the long one that you just said? All right, okay, got it, okay. All right, everybody remember?
Yes.
Pretty much, vaguely? Okay, all in favor?
Aye.
Opposed? Oh, it's not on. Okay. So afraid you're going to hear me breathe during when everyone's talking. All right, so we're going to vote on the motion that was made. All in favor?
Aye.
Opposed? Motion carries.
Okay, Madam Chair, we only have 3 items left.
Yeah, and they're...
Okay, so the next one, if I could, Madam Chair, suggest is the helicopter issue. So what this one is would authorize Meritain to negotiate any helicopter fares or charges that are there to do their best efforts to get any reduction off of the billed charges. There is a percentage of savings charged to it for anything they get from between what's billed and what's ultimately paid. I would suggest doing that with the additional direction that if Meritain gets to a point with a provider where they're going to balance bill the member, that staff be authorized to authorize them to pay the balance so we don't get an employee caught in the middle.
Okay. Anyone?
I wouldn't.
You want to do it? You don't want to do it?
Not going
to. Stay here.
Just, Madam Chairman, Aaron said that he was aware of one incident. Is there any additional cost for this service, or is it just authorizing a negotiation?
Just authorize negotiation. If it's actually successful, Mike, then they get a percentage of the savings off from what was billed to what was actually paid. and that's it. So it's no cost.
And Madam Chairman, Aaron, is there any downside? You said that it could get an employee in the middle of something.
No.
Could you?
The way this motion is structured, it takes that out.
Okay.
It eliminates that issue, because if it gets to the point where the provider refuses to accept the payment, then we can override and just tell them pay it, and that way the employee never gets there.
And so I would so move to approve.
All in favor?
Aye.
Opposed? Okay, motion carries.
Okay, Madam Chair, the next one on my list is the Livongo whole person. So this is the one that Susie was asking about. It's an expansion off of the diabetes to cover cardiac and pre-diabetes. It's a projected cost of about $78,000 a year in addition to the $50,000 we're currently spending. So it's an expansion of that program to cover those 3 additional disease states.
Okay. I have my opinion on this, and I've been here now, this is going into my 8th year, and just seeing the kinds of, because I do think this is more as preventative wellness, and seeing the usage, I just don't think that our employees are going to use it to justify that cost.
Chair?
I agree.
I think I might have the opposite opinion, because I know when Livongo came in and sold us on the diabetes program, they told us how much it was going to save if people signed up. And I believe this is our 2nd year, and the first year was kind of slow pace getting people involved, but that's picked up and maintained. And so if we believed the cost savings at that time, and we've successfully added people to our program who are apparently being successful, then I think, another additional preventative program, because so much of our expense is those top 2 or 3 areas, I kind of think it might be worth trying. They don't have it, I know in our book we don't have anything to see any cost savings, because, we had a new Navitus or whatever they're called for our prescriptions, so we didn't have any comparison there. But next year we would have the same program and be able to compare it and see if there was cost savings. So I'm kind of leaning the other way.
Okay. Susie? Oh, Roger.
Well, Madam Chair, I guess it's just the small numbers that have me concerned about implementing it, at this time.
Madam Chairman, I think we already have a diabetes program, and I think we need to get that program to fly.
Which program?
The diabetes management program, right? We currently have that. We've funded that. I think we have that for the employees. At this point, I don't see justifying probably this program at this point.
Okay. Mike, you want to weigh in?
I would have to side with this side of the table, because I believe our diabetes program is very successful. You said we had phenomenal participation based on other things. I'm not sure. And I think that's partially because we provide them with the slips free of charge, whatever those are, the testing strips. And I just don't see, that the other less critical afflictions having that and treatable, like the heart issues, as being as popular as this diabetes program. So I would be voting no. Thank you.
Okay, and do you want to say anything else?
One more thing. I can't find the page now that I'm looking for, but if I recall, like our top 10 users were all 3 in this category and used those type of prescriptions and had those type of ailments. So if they're using 25%, just 10 people are using 25% of our resources. if we don't have programs, preventative programs like this, how do we reduce that top 25% of our funds?
Well, again, the assumption is that those people will, which we don't know, and history says that they don't. And I just want to reiterate something Mike said, that it is a gray area, that diabetes is already been diagnosed and they're already doing stuff, and this makes it easier, makes it less expensive, stuff like that. And human nature is just don't do anything until it's there. And we've had plenty of things, wellness and stuff like that. And again, yeah, we've seen our wellness grow, but it's just the people who take care of themselves. You know, they're going to do. It's like the same thing we talked years ago about the gym memberships. People who go to the gyms are going to go anyway. We're not going to incentivize them to go. And that's kind of how I feel about this. But again, the unknown is how many people would. Maybe there would be. Maybe it would. But for that amount of money, I'm not sure that it's worth the gamble.
And Madam Chair, in the spirit of providing information, okay, the $78,000 is not a fixed cost. It's our estimate based on what percentage we think might enroll. So to the degree they don't enroll, there's no charge.
Well, how much does it turn out per employee who enrolls?
It depends on the number of conditions they have, okay? So but we believe that 78 is a realistic number. So my intent is only to say it's not a fixed cost, it's based on enrollment. So if they don't enroll, you don't spend the money, period. And then Verlin is correct that it is targeting that area where our claims are coming from. Whether it would be successful is the issue you're debating, and I understand that, okay? So because a program like this, like the diabetes, is contingent on people taking the step to enroll, that's what you're guessing on. Frankly, if they don't, your cost won't be there, but it is targeted at that, what I referred to earlier as the guardian knot, which is those high areas where we know the claims are coming from. It's one of the high areas our claims are coming from.
So they're charged per ailment? Because you said it's not a fixed cost per... Huh?
Well, because each of those ones brings with it different equipment. So if your issue is just pre-diabetes, but you're not high blood pressure, you only get the scale and that counseling. If you have the high blood pressure, then you get the monitor, the blood pressure cuff and that monitor. So there are components to it that are varied. What you're essentially getting is the counseling and the equipment that is specific to your combination of disease states.
Madam Chairman. I think my mother had all three and just going through taking care of her. She has insurance. The primary provider provides some of those care for her. And even KMRC has a lot of programs that would help employees or individuals prevent some of those. I think what I'm saying here is that the cost we're paying are the equipment and the counseling. It's not really the program, right? Because what you're saying is that you're not paying for $78,000, you're paying per employee that may participate, that would pay for the testing, the case management, or the counseling, or the coaching part of it. I think those are available in the area. These are available through your insurance. These are available through your primary care, through your insurance. So I think we have some resources to be able to give our employees to do that, rather than paying for a program through the trust money to pay for the things that they're going to get. I mean, my mother got some free of those from the primary physicians.
And again, I want to make clear, I'm not advocating, I'm trying to give information. Okay, I do believe would be a good effort, but I'm trying to be objective and just answer that. And Madam Chair, with respect, Susie, I think you're wrong, because what this does it in the home on a continual basis versus appointments that you may not be able to get. So it's an ongoing 24/7 cellular enabled. So every time they put that blood pressure cuff on, and it registers, it uploads the results, which tells you how effectively the disease state's being managed. If the issue is pre-diabetes and the weight that comes with it, every time they step on the scale, it goes. So you don't have to wait for an appointment. And that's kind of the key. And I believe that's why the diabetes program has been so successful, because you don't have to wait for an appointment to meet a provider. It's not about a provider, it's about giving you the information and the resources to manage your disease state if you elect to care. So what we're really doing is kind of empowering the employees by these types of things. Whether you vote for it or not, whether you think it's going to work is really what's important. But I just want you to understand it is a shift, because the concept is not delivering care, it's having people manage themselves. And the idea is to arrest their slide into the disease progression that ultimately hurts them and costs the trust money. It's a new concept. I mean, this stuff's only been around for about 10 years. We've seen very good growth in the technology. You have to make the decision if you think your employees will take it and use it.
Your estimate is 78,000. And you said how many employees did you predict based on how many employees?
Missy, could you flip to that slide and give me those figures on how many by disease state we budgeted that 78 based on?
And we're going to only pay for those who sign up.
Correct.
Yep. So as far as the prediabetes solution, I estimated based on national statistics that 478 would be eligible, 10% would enroll, and so projected 48 individuals, which would be 43.
So 43, into 78,000. So what would that be per?
One disease state. So then what did you put in for BMI and for cardiac?
One disease.
So the prediabetes and the weight kind of are actually combined together. As far as the cardiovascular solution, which is what they call it, so that's the heart risk, the hypertension program, estimating about 31 would be enrolled in that program.
So between all of them exclusive of diabetes, what was the number? I think that's what the supervisor's looking for. If you just took all of the numbers, because she's trying to divide that 78,000 by the number of people that would be enrolled. So what was the total number, regardless of disease state, that was figured on?
So when I did my calculations, including diabetes, it was 132,000.
Yeah, take
the 54,000 that we.
Take the diabetes out, because this is they're only questioning the expansion.
Okay, so it's looking at about 63,000, assuming we'll have additional going into that diabetes program as well. So from what I see, from what I had budgeted, which may be a little bit different than the X sheet, I see 63,000.
And how many new enrollees?
In my calculation.
But what she's getting at is how many new enrollees does that assume? People.
I see 79.
Okay, 79 new enrollees. So about $1,000 a person, which is consistent. It's about $900 a
I
year.
wish sometimes that we could do surveys with our employees before we make these decisions to see if it's something that they want. And if we're going to come back and kind of vote on something else before the new fiscal year, is this something we can do? Can we put out some kind of survey to see if people would want something like this? Every time we kind of do this, and the diabetes was how old? Like 2 years we've been doing this?
I think we're coming into our third.
This brings me back, and I just have to say this, and Mike will probably remember, and you'll probably remember, my first year, 2013, remember that? And
I know what you're about to say,
I was new, and, we had our annual meeting over in Laughlin, and I was shocked by some of the proposals, and one of them was the moms and the pops, and I remember saying, are you telling me that people are so lazy that they need the equipment to come to them? Like they can't schedule their own. And, I think some of it has bared out that, the pops, that they're not utilizing it. But again, we're paying per thing. But on the moms, we have, So, I've softened a lot on that kind of thing. But, this is kind of just a vague. And again, even if they get the material and they get the equipment, are they going to do it? And they can do it. People who are motivated are going to do it. They're going to do it like she was saying with their doctors, with their this. So again, I would just rather wait on this and then maybe send out a survey and find out if this is a benefit that people would use. Is there a way we can do that? Maybe on our employee website, do like one of those survey monkeys or something? And of course, it would be anonymous.
Yes, we do have SurveyMonkey that we can send out a system-wide survey.
Okay.
But how do you target just those individuals? Because
there's no way to target just those individuals.
Yeah, theirs is based on the medication.
Right, but you could say,
otherwise it's a HIPAA violation.
If you are in this category.
What percentage of the people eligible for the diabetes program participate?
I'm sorry, Verlyn, say that again.
What what percentage of the employees that are eligible for the diabetes program participate in that?
Okay, so Missy, of the diabetic population, which we measure by the people that are receiving diabetic meds, what percentage are enrolled?
I'm looking at that right now, so just one moment.
Yeah, 34.
34%?
Well, I'm going to have to go to my spreadsheet. I had listed
that's projected.
as far as medications. One second.
We have actual
We
enrollment
have currently
numbers, I
enrolled
believe.
53.
Mike Scott, you're looking at a slide, Mike?
Yeah, but this is projected. I think she just said 53, so we're way above projected, I would assume.
I think so, but she's looking at her spread. I think we were above what the, frankly, that's part of the reasoning we came forward with this, is the diabetes program here has had such good enrollment beyond normal. That's what I was getting at. We thought the employees would uptake as well on this one.
Okay, can we just then table this and then do this survey, and then if there's a need, when we come back for this other thing?
We're fine with that. And
that
again, I
okay?
want to stress, you're asking great questions. Don't feel any pressure. It's a recommendation, that's it.
Right.
Nothing
I mean, I
that
see
we're
both
recommending.
sides. I do.
Nothing that we're recommending was scribbled on a stone and walked off a mountain. They're suggestions.
Right.
But we'll come back when we come back on the other item, which is the psych item with the pricing. We'll include some additional background.
Right.
If you want, and if you don't, then we're done. We'll bring it up next year.
Okay. All right, anyone else?
Last one is the Copay Max program for, did you want to implement the Copay Max program on the diabetes for, prescription drugs for specialty medications? And if you want me to restate it again, I'll be happy to do that.
No. Thank you. Please.
It's your last item, right?
Madam Chairman?
Yes.
I would make a motion to implement that program.
Okay. All in favor? Aye. Opposed?
Aye.
Okay. It's passed.
Okay, so let me just recap what you've done. So,
Please.
and that way you know, because then I would suggest that I'll give you a final suggestion at the end. So we're going to implement the helicopter issue with the understanding that that if it gets to a point where the helicopter provider refuses to accept the negotiated amount, ECA will authorize full payment of the original bill. You have implemented the Copay Max program on the prescription program. You have implemented 100% for preventative care on the low dental. You've awarded the contract for life, short-term disability, and voluntary term life to Securian. And then ECA is going to work with the actuary and come back with any funding impacts and the benefit design to implement teledoc telepsychiatry services. And then we're also going to, we're going to work with staff on the issue of the sheriff's office and how we fix the EAP hole. And we'll bring that back with the telepsychiatry at the next meeting. Okay, so ECA's recommendation, if you are agreeable that that is an accurate summary, did I miss anything? No. Is that you do all of that and that we hold the rates flat for the 2021 plan year.
Okay.
Madam Chairman, the bottom line for county employees, is their premium going to go up?
No.
Here's what I can tell you, Madam Chair and Susie, based on what we did today, the premiums will not change. How the county elects to share that is a decision that's not for the trust, it's for county staff. But there will be no premium changes as far as what the trust collects from the county for any of the tiers involved.
So the county employees will not see any change in their premium? Or
I
we
can't
have
do
not
that
made
one.
that decision yet?
Yeah.
Madam Chairman, Aaron, and that's the question I would ask. We would need clarification. With what's being proposed, is there any change in the employees? Would there be any change in the employees' premium?
That's what I'm trying to say, Mike. There's no change in the premiums overall, but the trustees don't ultimately make the decision how the cost shares go. But
we make the recommendation.
Right.
And what I think where Susie is going and where I was going to go with this is that the trust is doing very, very well. And what we did last year and what we have been doing, especially in these difficult times, is that if the percentages of what the employee share would be as opposed to what the county share would be needs to change so the employee would have no increase in premiums, then that would be something that would be contemplated by the trust. And I just earlier spoke to our finance director, and that would be an appropriate move for the trust if that's what we wanted to do.
Yeah.
Thank you.
But when do we make that decision in the
I think you're about to vote on it.
Today?
I think you're about to vote on it. Is that the intent, Mike?
Accept the
Since the premiums aren't changing, the employee costs shares would not change?
Are you making that motion, Mike?
I would make that motion, yes.
I second.
Oh.
That was a fast one.
Okay. We got a motion and second. All in favor?
Aye.
Aye.
Opposed? Okay. Thank you. You got
Hey.
to it finally.
Madam Chair, the last item on the agenda is the administrative update. And if I can just walk through that, it's a non-action item. So ECA is going to be working with the county staff on open enrollment prep, which will include noticing people of what the benefit changes are, and it'll include also specifically on that voluntary term life and any other changes the board has done. We will then work on developing the risk management plan. Susie, that's one we'll get you an older one, but you'll see it. It's essentially the business plan for the year. It encapsulates all this and then sets out our work goals, which will include an RFP. And then, just as an update, Ken, on dual spouse. Okay, so that one will come back later on, so no action on that. So that's all, Madam Chair, from ECA's perspective, we always say this, that we don't have anything further. We really appreciate, we were commenting before, we can watch all of your wheels turn. I would say thank you for doing that. Please ask questions. We are afraid, like you are oftentimes, when people are silent. As a parent, I always checked on my kids when they were quiet, right? But your engagement is exactly what your fiduciary obligation is. So the intensity of your discussion, and I also say, you guys have always been respectful to each other. So I know it's probably not my role to say, but you're doing exactly what you're supposed to do by challenging, asking questions, make sure you understand. And you did it again this year in high pressure. So thank you from our side. It makes our jobs easier so we can make sure we're giving you what you're asking for.
And thank you, Erin Collins, and your staff for, being so flexible with all of this. It was changing on an hourly basis, and thank you to the vendors who called in. I hope next year we'll be back to normal, because I was telling Mike earlier, these annual meetings are some of my favorite meetings because I learn a lot. I get to meet the people who provide this, and we get the numbers, and we get to see the health of the county. And so this was not really truly indicative for our new member of what our annual meeting is, but I think given the circumstances, it was excellent.
Thank you, Madam Chair.
Yes.
I have two questions. Erin, will you follow up with us and let us know if those screenings that are canceled, if we do have to pay a penalty? And the second question I have is, what happened with the whole Mayo Clinic issue?
One on the vendor charges, we will do that at a future meeting once we know. So we'll make sure we'll do a running tally on that because we have to do the budget impact. So we will do that. Mayo Clinic has been approved to stay at your option to remain out until 2021. So as of this year, Mayo will stay. Mayo's always in for a very specific list of specialty procedures, solid organ transplants. There's a mechanism to override to allow them to be treated as an in-network vendor if there's not a specific vendor available, period. So we've got that. But for general services, they remain out of the network unless the trust asks that they be added, and then we would have the actuary update the costs for adding them. My recollection, I'm getting gray-haired here, but my recollection is it was an additional 6% on the rate to allow Mayo in on a regular basis as an in-network provider. So I would have to get that updated if you wanted to look at that.
Okay, because at one point, I thought we were going to be forced to go that direction, and then they backed off. So that's no longer on the table.
It's not on the table now. They've only guaranteed it until June 30 of 2021, that we will not be forced to add them in.
Madam Chairman, first of all, thank you. Being the newest member of the board, this was really a learning curve for me, and I've learned a lot in this meeting. But I have one question for you, Erin. Since the providers for the EAP program is not performing at this time, can we cancel their contract now for non-performance?
That's I haven't looked at that. We probably could.
I mean, we still have a few months. I mean, I know through the end of the fiscal year, they have a contract with us, but since they have not been performing and our employees cannot access the services, can we cancel their contract now
I'll have
and
to
not
look
pay
into
them?
it. I'll look into it with Ryan and with Ken and see if the contract allows that. And the non-performance means that in some cases the vendors are not accepting, so their contracted people are not accepting. But I want to quantify that, Susie, to make sure, and then we can get with Ryan on legals to make sure that what the contract is.
Thank
if
you.
they're in breach. So that's a good suggestion.
Thank you.
Okay. With this, any other questions, comments, praise, scorn? Nothing? Then we're adjourned. Thank you so much.
Thank you, Erin.
What?